be a club song. I do the breakfast in the morning too.
Is this where she's sitting?
How are you?
Good to see you.
Good to see you as well.
I live.
So I gotta be really careful.
So fine.
Jack's
Such a good boy.
I know,
Really are.
he's enjoying it, and I think he's playing pretty well too for like, you know, how his arm, and if you're kind of nervous, like, it's gonna come out. I think anyway, yeah,
Great. Good. It's been good.
yes. I know, I'm so excited.
We're ready. You got their attention.
Good afternoon, everyone. You guys ready to get started?
Yes.
All right.
Same cut, but.
Well, good afternoon. My name is Angelina Moore. I'm the Director of Community Initiatives, and it is my pleasure to welcome you to the Children's Museum for the Indiana Behavioral Health Commission meeting. We are grateful to be able to work alongside you to be an accessible community resource to support the mental and emotional wellness of youth and families. Currently, as you may know, because I think you just came from the exhibition, an exhibit that focuses on emotions. It's called Emotions at Play with Disney Pixar's Inside Out. And it focuses on the 5 core emotions: anger, joy, fear, and disgust. And it also, it's an interactive exhibit, as I imagine you probably experienced, that helps visitors of all ages to be able to understand the importance of emotions, feelings, and imagination, and how they play in our everyday lives. It also teaches you about the importance of emotional well-being, which our young people really need to understand, because emotional well-being is not just about being happy. It's about understanding the emotions that we have and that they're tools for us to express how we're feeling and to communicate. Also, in addition to the exhibits and cultural opportunities that we have here, we want to make sure that the museum is an accessible resource to all children and families, regardless of their socioeconomic background. So we do have a number of free and reduced admissions programs, and information about that is actually in the handouts that I placed in front of your name tents. And if you didn't get one, please see me and I'll make sure that you get that. I will also send it to Jay, I think, electronically, so you'll have those resources and be able to share with your network as well. That's okay. So just to give you an overview of what some of those programs are, the first one I want to share with you is about our Access Pass program. That's a statewide reduced admissions program. So it allows the Indiana residents that receive state benefits like SNAP, TANF, Medicaid, and WIC to be able to pay $2 for general admission, not only to the Children's Museum, but also to a network of other participating locations across the state. Additionally, we have another reduced admissions program, which is on the first Thursday of the month during the hours of 4 to 8, where you're able to pay $6 for general admission. And then we have free membership programs for Indiana foster families, as well as residents that live in the 6 neighborhoods that surround the museum. And also we have a number of free admission days throughout the year. Our next one coming up is going to be on Saturday, June 1st. That's going to be our annual Juneteenth Jamboree celebration. Hopefully you saw the nice sign as you walked across the skywalk promoting that that's going to be our next free admission day. So these are just some of the ways that we would like, that we're wanting to be more accessible to the families that live in Indiana. So please help get the word out, share that with your network. If you have any questions, please see me afterwards. And I'll also make sure that Jay has my contact information to share with you. So again, welcome. And I hope being here today inspires a healthy discussion and generate ideas on how we can work collectively to be a better resource to Indiana families. Thank you.
All right, thank you so much to Angelina and the Children's Museum. I really appreciate the opportunity to have our meeting here. I won't bore anyone with the logistics of how it happened, except for thank you so much to DMHA and other staff for making this happen, because it takes a lot of work to get outside of the government center, but I think it's worth it. So real quick, some business. Did everybody have a chance to review the minutes from the last meeting? Any changes? Motion to approve?
So moved. I'll say.
All in favor? All right, we're good. That's the business to take care of today. So this will be it's our third meeting. This is our last sort of population-specific focus meeting. So there'll be a lot of information. I will say, like, every single one of these topics could be in our entire like conferences. And we've asked our presenters to do the impossible and talk about them in like 10 minutes. So the point of this is not to get too specific suggestions, but it's more to give everybody an overview of the things that we are all kind of collectively facing. There will be a form going out this week or next week by email to all commission members with the ability to submit suggestions for what goes in the final report. And so we'll kind of take a look at that and, you know, duke it out at our next meeting. So we look forward to that. I will say I was feeling a lot of fear before this meeting started. I think that will slowly shift and start move towards sort of anger, disgust, and sadness when we think about how we're failing our kiddos. But I also am full of, you know, hope and I say joy with, you know, all these people coming together to figure out what we need to do. We'll sort of end with, you know, one of Senator Crider's constituents. There was this news article about a 10-year-old boy who died by suicide, which, you know, as a parent, that's, you know, absolutely heartbreaking. And I don't want to litigate whether or not a better system could have helped him. That's a case-by-case situation. But when we think about, especially, you know, the day after Mother's Day, and, you know, we're all celebrating our moms and our families, that there's a lot of moms and families around the state that are going through a lot of hard times, and we have the ability to help them. And so we need to be bold. We need to make sure we don't pull our punches when we come up with our recommendations. So with that, I will turn it over to our first speaker, Zach Adams.
As a native Hoosier and a dad raising his kids in central Indiana, I've spent a lot of time here at the Children's Museum. And then as a clinical psychologist who grew up in the 80s and 90s, I felt right at home with the Inside Out on one hand and the Ninja Turtles exhibit on the other. So thanks for the opportunity to share a little bit about the work that we're doing to support not only kids and families, but also primary care providers and other healthcare professionals across the state who are very much part of the workforce that's delivering mental health care to Hoosiers. I'm here as co-director of the Indiana Behavioral Health Access Program for Youth. I say co-director, the other director happens to be in this room, Dr. Yoder. And I was asked to not only say a little bit about the Be Happy program and other access programs, but also the state of affairs with respect to pediatric mental health here in Indiana and nationally. So hopefully it's not a surprise to anybody in this room that we're really in an unfortunately unprecedented time with respect to what's going on with child mental health. In fact, just a couple of years ago, the three leading professional associations that have a stake in this, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association all issued a joint statement describing this as a public health emergency around pediatric mental health. So what does that look like when we think about some of the numbers? Well, there's a lot of data that we could present, and as Jay said, we were asked to do the impossible and distill things down into just a few minutes. So a few highlights to note. What you're seeing on the screen now are data from the National Survey of Children's Health, and the question that was asked here is a fairly straightforward one. Have you heard from your child's doctor or other folks that are taking care of your kid that they have an emotional, behavioral, or developmental condition? This is for kids between the ages of 3 and 17. And so what we see here is the blue line represents Indiana data, the yellow line represents national data, and Indiana trends sort of track what we're seeing nationwide, and if anything are a little bit higher, such that in 2020, 2021, we saw rates of roughly 28% of Hoosier kids having an emotional, behavioral, and developmental condition. That equates to over 366,000 kids in our state. Continuing along these lines, if we look at data from the kids themselves, straight from their sort of experience, these are data from the High School Youth Risk Behavior Survey. The most recent data that we can pull with some confidence come from 2021. And what you're seeing here is not just did they experience any stress, anxiety, or depression, because we know that's part of the human condition, but rather over the last 30 days, would you say most of the time or always that was a central concern for you? What we see here again on the left is Indiana, on the right is United States, and roughly 1 in 3 high schoolers in our state say that nearly every day, if not every day, stress, depression, anxiety is a central concern for them. I also want to highlight here, for those who can see the pointer, that we see differences between boys and girls, such that 44% of girls and 17% of boys are endorsing that. You know, we just heard about one of the most tragic consequences that any family can experience, and certainly within mental health, it's one of the outcomes that, you know, we all do everything we can to prevent, and that's suicide. And the next couple of slides present some data related to thoughts of suicide, attempted suicide, and plans for suicide. This is from that same survey asking adolescents in the 12 months prior to this survey, did you seriously consider ending your life? And what we see here again, these are Indiana data, on average, 1 in 4, more than 1 in 4 Hoosier youth endorse that item. And again, when we break it out by boys and girls, we see higher rates among girls, with nearly 40% of girls saying that they've seriously considered suicide in the past year. Now, public health emergency, that may be obvious, but I think another reason this call was issued recently is it's not just that these rates are high, it's that these figures are growing. We're seeing not only high, but rising rates of suicidality and mental health concerns among kids. This is attempted suicide, 16% of girls, 11% of Hoosier youth overall. And then just want to sort of briefly note, I've sort of been making this point already, that not all youth experience similar levels of risk, vulnerability, et cetera. And when we are able to disaggregate data based on a variety of characteristics, including race, age, sexual orientation, we also see variation across the population. I really want to call attention down to the bottom right corner here, where we see the adolescents who identify as gay, lesbian, or bisexual, or other questioning, that half or more are endorsing that in the last year they made a plan around how they would attempt suicide. So, you know, if there's a question about why the alarm bells are ringing, these are some data points that remind us of that. Also here, because we're convened around the Behavioral Health Commission, and sometimes we use that term to refer to mental health and substance use concerns. And, you know, today's focus is on pediatric issues. Substance use is very much a pediatric issue. Substance use starts, the development of substance use disorder begins. Many kids are struggling with patterns of use that are leading to overdose, landing kids in our hospitals and other settings. And overdose has crept into the leading causes of death for adolescents in our country. So really this figure is not so much meant to be a comprehensive picture of substance use in our state, but rather a reminder that many, many youth are starting to use substances and developing problems. And just to spotlight one example, binge drinking, for example, 8% of 12th graders say in the past month they had 5 or more alcoholic beverages in a sitting. You know, one big public health win, relatively low rates of cigarette smoking, but that's been replaced by very high rates of vaping, both of nicotine products and cannabis products that are very high in terms of their THC concentration, leading to consequences that I'd be glad to describe on a different day. So that in and of itself is cause for concern. But that's also coupled with some real shortcomings in our infrastructure and our capacity to respond. And so there's lots of different ways to look at this, but one way to think about it is that as many as 2/3 of kids who meet criteria for psychiatric disorders, have behavioral health concerns, and might benefit from treatment services, never receive them. And there's a lot of reasons for that. There's a lot of barriers, a lot of hurdles that are out there. And as this group knows, one of them is that we simply don't have enough behavioral health specialists in the workforce to meet that need, to meet that demand. And what's being presented on the screen right now is really just one small snapshot of what that looks like nationally. So what we're looking at here is a couple of maps that depict not the behavioral health workforce generally, but specifically access to child and adolescent psychiatrists. And so, you know, this is one of those figures where the colors are sort of intuitive. Green means good. There's not a lot of green on this map, right? And in fact, if we look at the colors, Orange is severe shortage. Red means none at all, okay? So if we look across the country, almost the entire country is in a severe shortage condition with respect to access to child psychiatrists. And when we look at the county level, much of our country is lacking. Well, that's a problem, and it tells us something about our neighbors and the general condition, but we're here to talk a little bit about Indiana. And when we zoom in, the picture isn't a lot rosier. It's redder, but it's not rosier. And so what we see here, again, shortages across the state. And one thing to note is even in places that have sort of more child psychiatrists practicing in that county, those also tend to be our more populated areas. So when we think about, do we have enough per capita child psychiatrists to meet the demand, we're seeing really across the board major shortages. So not surprisingly, that's led folks to think about how do we sort of meet the need and fit the gap. Well, I think it's important to say that a comment I mentioned before, to return to that child psychiatrists and psychologists and social workers and so forth represent an important part of the behavioral health workforce, right? But in actuality, primary care providers offer the most direct mental health care of really any healthcare professional. There's data to suggest that for many kids, pediatricians and other primary care providers are the sole providers of their mental health care. And certainly, if we look at some of the other notes on the board, these are healthcare providers that are trusted by families. In general, they're more geographically accessible. There's less stigma around going to your PCP than there is going to a mental health clinic for many families. And it turns out that many primary care providers have really solid training in mental health care, but also in addressing complex healthcare needs, in forming and developing relationships with families, and providing developmentally appropriate care. But as many as 2 in 3 pediatricians say, even though this is something that I do day in and day out as part of my practice, 2 out of 3 say I don't really feel fully resourced or supported to take care of my patients in the ways that they might need. So this model was developed several years ago, initially in Massachusetts, and now it's spread nationwide thanks to a variety of sources, including an initiative through the Federal Institute of HRSA, such that almost every state, territory, and tribal nation now has what's called a Child Psychiatry Access Program or a Pediatric Mental Health Care Access Program. The basic notion here is that if you're a primary care provider taking care of a patient with a mental health condition and you're feeling like you are a little stuck, and maybe you've started something, maybe you have identified through screening and assessment a need, and you're just not sure what your next steps are. In fact, you're not even sure if you need to make a referral to a child psychiatrist. You can pick up the phone and at no cost to you, speak to a child psychiatrist about what your patient might need. So here in Indiana, the program that we've offered statewide since 2019 is the Indiana Behavioral Health Care Access Program for Youth, or Be Happy. And our core service are those provider-to-provider consultations. But we also provide continuing education, some direct services, referral support, and some specific suicide prevention services. The process is pretty straightforward. Somebody from the clinic, primary care clinic, either fills out a form or calls our group and provides a little bit of basic information. They get a call back from a psychiatrist at a time that's convenient to them. Usually it's within a few minutes, and have a brief conversation that leads to a set of written recommendations and next steps. A couple more slides just to say a little bit more about what the impact has been. So even though our logo is yellow, blue is the color to pay attention to here. So our program has fielded, as of a couple weeks ago, close to 3,000 consultation calls and has enrolled over 930 primary care providers. If we look at where these folks are working, the providers are stationed in over 77 Indiana counties, serving children who reside in 88 counties. And one thing I really want to emphasize here is that each of these calls or consultations, of course, it benefits the family and the child that they're calling about. But now that PCP knows something about how to take care of patients with similar needs when they come in the door. So we imagine the impact to be greater than what we see. The calls come in, so what's common is common. ADHD, depression, anxiety, that's the majority of the calls. And when we think about how severe are the calls that are coming in, it's actually what we would expect. Kind of complicated, but not so much that we don't think it's appropriate for this patient to be seen on an outpatient basis. And this is a figure I'm both proud of and think is important for folks to have in mind. That after these consultation calls, we take a look at sort of what the recommended next step is. And in over half of the cases, the child stays with the PCP for full management of whatever is going on. So usually that means maybe an adjustment to a medication, maybe it means connecting them to another resource. But in over half of cases where perhaps they would have been referred to a psychiatrist and sat on a wait list for a long time, they're already in the clinic and the PCP is able to give them what they need right then and there, and then follow up over time. And in 41% of cases, the vast majority of the remainder, they're still staying with their PCP who now has some next steps while they wait to get in to see a specialist. We have lots of these quotes, but just want to share a couple. I'm so thankful for Be Happy. It's enabled me to keep from feeling like I'm drowning as I work to address the huge increases in mental health needs among my patients. This is from a PCP who used the service. Thanks a million times. Our program has grown thanks in large part to support from DMHA and other sources to not only focus on the mental health care needs of our kids and families, but also help address the needs of kids with substance use disorders. And then we're really excited that in the last couple of years, there's been an opportunity to launch a program that focuses on adult psychiatric needs across mental health and substance use, where over a third of the calls have come in related to the needs of perinatal populations. So again, we're thinking about how to take care of kids and families. A really important dynamic there is making sure that caregivers have what they need to be safe and healthy. Everything you've heard about so far has been supported with grant and contract dollars to date. Some of those have been from the state, some have been through federal pass-through dollars, some have been through philanthropic gifts. All of that is time limited. Our HRSA grant that supports the core consultation services, for example, expires in 2026. And so, as some of you are well aware, we've been having lots of conversations about how to sustain this work and how to keep this resource available, not only to, again, the kids and families that benefit from it, but the healthcare providers who take advantage of it. There's a lot of different ways states have explored to do this, including some legislation for line items in the budget. But an emerging best practice that we think actually is a really exciting and flexible model is one where essentially there's a program set up where insurance carriers operating in the state cover a proportional share of the cost of operating these access lines. And in Washington, for example, this was like 6 cents per covered life for those insurance companies. Ends up being managed by a board that represents state organizations, health insurance providers, and so forth. It's a model, like I said, it's been adopted elsewhere. We've been keeping an eye on it, and we think it could be a good fit here. So anyway, thank you for your time and attention and the opportunity.
Thank you, Zach. Really appreciate it. Moving right along, we got Dr. Broderick here. Just gonna keep coming up. But while she's walking up there, I guess I want to point out like a recurring theme I think will be sustainable funding for these things, right? So let's keep that in mind as we're talking about everything we're talking about.
Thank you. So my name is Amanda Broderick. I'm a licensed clinical psychologist, and I'm here on behalf of my role as the clinical director of the Riley Multisystemic Therapy Program. Before I jump in, I just want to give a nod to Dr. Gabby Rodriguez, who really spearheaded the statewide implementation of this program, and she is really the source for many of the information on the slides that I'm going to be presenting on. So multisystemic therapy is an evidence-based intervention for youth with serious conduct problems. So the goal of MST is to reduce or prevent involvement in juvenile justice or out-of-home placement. And the way we do this is we think about all of the different systems surrounding a youth. So we think about the individual, the family level, school, community, and peers. And what we theorize and what the research supports is if you can make changes in those environments, you can change a youth's behavior. So this is an intensive program. Therapists meet with families about 2 to 3 times per week, but it's also pretty short term. So we see outcomes within 3 to 5 months of working with families. And one of the pieces here is that we provide 24/7 access for families to be able to talk with the therapist as crises arise, rather than waiting until the next scheduled session to solve problems. So youth are eligible for this program if they're between the ages of 12 and 17 and are at risk for serious system consequences. And we define that really broadly. That may be juvenile justice or probation involvement, that may be on the way there, that may be DCS involvement, they may be getting in trouble at school, they might already have been expelled from school. And the behaviors that put them at risk for those consequences are pretty serious. So things like running away, theft, physical and verbal aggression, selling substances, using substances, and behaviors that generally get kids in trouble at school or in the home. So I want to highlight that this is a really high risk population, it's really high needs, and it historically has been quite costly. So these are potential interventions that an MST family could access through their therapist. So when we think about a family, this is an in-home program. So we're meeting at the home, in the community, at the school with the probation officer. We come to the families to help them reduce any barriers to access. And so we think about each youth very specifically. We understand what are the specific drivers of those behaviors and what are our best known interventions for targeting those drivers. So it's not that every family receives all of these different services, it's that we tailor their interventions to be relevant to the particular family and youth configuration. So one family might receive substance use intervention and parent management training and peer interventions. And another family might need something that looks a little bit different, but their therapist can offer all of these particular interventions. So unsurprisingly, this is a pretty resource intensive intervention. So one MST team consists of one supervisor like myself, as well as 2 to 4 full-time dedicated therapists. So in other words, they're not doing anything besides MST. And therapists are only allowed to work with 5 families at a time. And the reason for that is we want therapists to be accessible to those families. It's high intensity. They need to be able to respond to families as those needs arise. There are also startup costs that come with MST. So there's an extensive program development process that makes sure that programs are viable so that you don't put all of this investment in for it to not be sustainable. There's significant training that happens at the beginning, and then we have ongoing costs. So things like consultation fees to make sure that we're adhering to the model with fidelity so that we're achieving the same results that the research has shown this program to achieve. And things like licensing fees so agencies can identify themselves as an MST provider. So when this project began over 5 years ago, there were no agencies in the state of Indiana providing standard MST services. And so part of the, through funding from DMHA, the statewide implementation project arose. And the idea is that all youth in Indiana could access MST services within 60 minutes of their house. So the goal was to subcontract with 12 agencies across the state and provide them with 2 years of financial support. And that covers a lot of the pieces that I have listed on the slide. So things like startup costs, consultation, administrative fees. In turn, each agency would be responsible for covering those other costs. So things like therapist salaries, supervisor salaries. So part of the implementation project provides support for teams that have been created. So that includes things like community of practice meetings where agencies across the state get together and we problem solve Indiana specific issues that come up with when we're working with MST. It involves a monthly newsletter, presentations to stakeholders, so that may be talking with judges or probation officers about MST so that we can help them understand how to make referrals, but also we can partner with them to be part of the intervention. And it also includes data collection. So this is from 2023. So across the state, we were able to work with 46 youth. Treatment on average lasted about 4 months. And at the close of treatment, 74% of youth were living at home, 85% were in school or working, and 83% had no new juvenile arrests since beginning their MST treatment. So this is a story from one of our Indiana MST therapists. So Emma struggled with regulating her emotions and impulsivity. And when she transferred back home from residential placement, her mom didn't feel safe and she didn't feel like she had the tools to effectively parent Emma. After meeting with her MST therapist, Emma started to use coping skills and she began to communicate better with her mom. Mom felt more comfortable setting boundaries. She didn't stop feeling guilty. She learned how to give effective rewards and consequences. And Mom and Emma they shared with their MST therapist that for the first time, they actually felt truly heard by a service provider. So their DCS and MST cases were closed successfully, and for the first time, the family felt hopeful for the future. So now that we're underway with this program, we want to talk about funding sustainability. So at this point, there are really two pathways in Indiana to have this be a sustainable program. And so most of the agencies so far have pursued a family preservation services contract. And so to be eligible for family preservation services, you may know, youth has to have an open DCS case and or a formal probation case. And this provides a per diem reimbursement rate. And that's relatively sufficient for what we need for MST. The problem with that is it misses a whole swath of Indiana youth who are eligible for MST services, but who aren't yet eligible for family preservation services because their behaviors haven't risen to the level of having an open DCS case, having juvenile justice involvement. And that's what MST is here to prevent, right? We don't want them to reach that level. So the other pathway right now, Riley is the only one who is pursuing this, and I will be honest, it's not a sustainable option, but it is a combination of billing Medicaid and private insurance and grant funding. This allows us to capture those youth who are not eligible for family preservation. But the problem with this is there are so many things baked into MST as part of our process that are simply not billable. So things like crisis calls or case management we can't submit claims for. But the numbers I have here, this was over a period of 8 months within our clinic. We are able to bill for face-to-face therapy sessions, and only 27% of what we had submitted was actually reimbursed. The other piece of this is that we have a DMHA no cost extension until September of 2025, but then beyond that, we need to think about what's next. So I just want to highlight, so the top part of the slide shows youth who started MST and they were already system involved. And in the bottom half of this, we have youth who came into MST and they hadn't yet been system involved. They don't have an open DCS case, they don't have probation involved. And the numbers on the top part of the slide are still good for this population, right? They're still effective, but it's really a striking comparison to look at the group who hasn't yet encountered that formal system involvement. And so what we want to do with MST is we want to be able to serve both of these populations. We want to serve the kids who are already involved, but we also want to disrupt that pipeline and be able to intervene and access those youth who are kind of on their way but aren't there yet. So I just want to end with a call to action to pursue an enhanced Medicaid reimbursement rate. So 11 states have already done this, and they've negotiated an MST specific rate. The average across these states is almost $40 per 15-minute unit, whereas kind of the Indiana version of this right now is approximately $21 to $25 per 15-minute unit. So if we were able to pursue this, we could expand access to MST across the state for youth who are already enrolled in Medicaid and yield a statewide cost savings for every Medicaid dollar spent on MST services. So with that, I will leave you. I got.
All right, thank you so much. Well, it was really informative, and I think again the common theme of sustainability and investment. I mean, we can't escape those themes in this conversation. So we're going to take a bit of a detour here. So I'd like to invite my friend Bob and his friend LaDonna, who I've not had the pleasure of meeting yet. We can't have this conversation without at least touching on the issue of youth and social media. It's too prevalent in the news headlines. And we could go down all kinds of rabbit holes, and I'm trying to avoid that because we're really jam-packed here. So I thought instead we could learn about what Bob and LaDonna are trying and leading at their school from the perspective of parents, and then we will have more robust conversations as a commission about this issue at some point. So I guess Bob, LaDonna, why don't you just let us know who you are and what you've been trying to accomplish.
I'm LaDonna Hughes. I'm a parent. My son's in St. Richard's the school. And really just as a parent, wanting to be more aware and conscious of what's going on with our kids. I have 5 children, ranging from adult to my son who is 7. And what they're experiencing and talking about and going through today is so totally different than what my children were doing previous to.
And I'm Bob Wood. My daughter is in her son's class, and then I have a younger son also. And this is sort of one of these things that grew out of a few parents, a critical mass of parents talking at birthday parties and pool parties and whatever over the course of maybe a year about our kids are in first, rising second grade. We're seeing older kids on devices all the time, on phones all the time. We're seeing now Jonathan Haidt's Anxious Generation book is everywhere, but at the time it was like, I've seen an article here and there about these harms, and people with older kids would say, I'm seeing it in my house. And so a few of us talked about what would it look like to try to build a cohort just in our grade, not with the school at the time, just to kind of remove the FOMO as the kids grow up, right? Because that's the social pressure is why you get the phones for your kids. And so could we build a cohort big enough to kind of push this off at least into high school? And so a few of them egged me on to write up this research-based email that I sent out in October. And within 24 hours, there are 32 people, 32 families in the second grade. And I posed it as a question of what if we all agreed? And people thought it was like a sign on the dotted line. Within 24 hours, we had 2/3 of the class who said, we're all in, no phones until high school. And it's grown a little bit since then. And now, since that email, the head of school is really interested in it. And so she's created a technology committee, and she wants the school to be a leader in this stuff. They're promulgating various policies, increasing across technology. Phones is one thing, but classroom use of technology and other things that all of this is really beyond any expertise I have. I'm just a parent. But and so I don't have a PowerPoint, and I don't think you brought one either. So this is just something that we grew in our grade. We'll see what it looks like for the whole school, and it was easier than I thought. And part of that is just the random luck of having kids who are still little. This is all an accident of history a little bit. And I know you had specific questions. So
Yeah, well, what's some of the pushback that you got? Some examples.
Maybe should I do that one since
Yeah.
I sent the thing out? So I would say that I haven't received any pushback in the form of, I disagree with you. These things are actually great for kids. I have not gotten that. I've gotten, it's inevitable, so why should I care? And I'd say I've gotten, I want to be in touch with my kid during school, right? And this is, again, beyond my competency. But what I've said to people like that, and I don't want to be in an argument with anybody, but this has been
Well, you're a
reinforced.
U.S. attorney. So
Yeah, that's right. I'm
I feel
a
like maybe
lawyer.
a little bit.
But I really don't. But this has been reinforced by our school culture is, there are other ways to stay in touch. It's not just at the school, the phones at the school. I know there's at least one educator here, probably many. But there are other kinds of phones that don't have these harms. You can get all the benefits without the harms. So if you really want to buy your kids something and you need to be in touch with them after school for this, that, or the other, you're worried about emergencies, there are other ways to do that. The other pushback, not a lot. I don't think there has been. There are people who stay silent, right? And I get that, and we want to respect that. We've tried to be as sensitive as possible with this stuff, and not, if you're going to go your own way, great, fine. We're just trying to make this as big of a group as we can, right?
Well, any questions? So really, the point of this, right, is to suggest that perhaps, like ideally, or in terms of state action about social media, I think there's lots of conversations, and we can have those conversations. But I think, from my perspective, and I think it's reinforced by your experience, like sort of empowering and educating parents, is to me the sort of lowest burden, lowest kind of slippery slope. Best approach. And I just, thank you for sharing your story.
I'd add that right now, because the media blitz on this book, right? This John Haidt book is so intense. The iron's hot, right? So back when we were talking about it last year, there were several families that were attuned to it, but a lot were like reasonably not paying attention to this stuff, right? But now more people are, And most people are interested in talking about it. And some of the most powerful anecdotes have come from people who, like Ladonna, but she has been an early leader on not giving these things to her kids, but some who buckled under the social pressure like anybody does and said their response to the email, and they replied all, multiple people did this, and many more have since then, when they've heard about it, have said, I just wish somebody had started a conversation like this, you know, for my older kids or for my older kid, because she or he is deep in a well at this point, and we were just doing what everybody else was doing. And it would have been great if what everybody else was doing was having more thoughtful conversations about this early on and hopefully putting this off for longer. And again, like I said, I haven't gotten anybody say, well, the data that academic performance is lower is wrong. Or the data that, I mean, we just saw these graphs about suicidal ideation and the timing of it. Nobody said, you know, that's wrong. And I know there are experts who argue with the height and gene twinking and people, but that's beyond my competency.
Mr. Chairman, may I ask a question? Yeah. So I don't know if you're familiar with this program, but I'm a product of the smoke-free class of 2000.
Yeah.
Remember that? But that was a real pledge that I signed in the 3rd grade and stuck in the back of my mind until young adulthood. So do you involve the children in signing such pledge?
I haven't. My son, who really like put the focus on this for me recently, doesn't really understand in the sense of what it really means to sign the pledge and what you're holding yourself accountable to. But my children previous to, we tried to be very holistic. You know, we wanted the basics without, you know, pretty much influence from other areas that we had no control over or weren't aware of where their bases were coming from. So for me, it was us just actually sitting down talking about like what's important to you and how you had other options, because it is peer pressure for the kids. My younger daughter, she was just like, why can't I just have a phone? You know, like everybody has it. But trying to put the focus more so on their education and where they should be focused at this point in time in their age, and how kids now are doing so much more at a younger age. It's like you want your kids just to be kids. Like they have plenty of time to be adults. And that was our basis. It was like just sitting down and saying, hey, like what's important? What do you want to do? And these are the options. And when they saw that there were other means to do so, that made it much easier for me.
And they quickly become attuned to it out in the world too, right? So I talked to, I sent my wife all in for this stuff. She hasn't had a smartphone since she switched a job and hasn't needed it for about a year. So we talked to the kids in the sense that, hey, some of the parents in the school are doing this and we're in this group. So if this discussion comes up, here's why we're doing it or whatever. And then we didn't say much more about like, you know, don't condemn people or, you know, whatever. But they'll say when we're out eating or whatever, and we have to kind of like, you know, sand off the rough edges of their judgments a little bit, but they'll say, you know, look at all those teenagers at that table at the pizza restaurant or whatever. They're not even talking to each other. And they'll know that they'll say it's because they're on their phones. And so you have to navigate with your kids being really thoughtful about this. Yes, that is supportive of what we're doing with you. And we hope that you internalize that as a reason you would feel empowered to, I don't know, sign a pledge, but to do this of your own agency. But also, you know, you have to see where people are and where they're coming from.
Any other comments or questions?
What is the name of the book?
The Anxious Generation. And it covers mostly the mental health stuff, but it also covers things like diminished academic performance around the globe. I read it, it's really good.
We'll put that in the minutes too.
Yeah.
Reference. All right, well, thank you so much. Really appreciate your time.
Thanks.
All right, moving right along. So this next presentation is a virtual presentation from the University of Connecticut, national champions. Sorry, Boilermakers in here. I apologize. So they have sort of taken on, they've created, they have quite a few experts at the center at UConn. We're working with a lot of states on kind of mapping out the continuum of care for the high acuity youth. So the children that Dr. Broderick mentioned in MST. So these are the kiddos with sort of intense emotional and trauma and all kinds of responses. And the main point of this whole presentation is the notion of the continuum. Okay, so you can't, one of the things I've noticed is a lot of people, the most important part of the system is the one that they're in direct contact with, right? And I think the truth is we have to look big picture and realize that the most important part of the system is that it's a system, right? And a continuum. And so, these folks will share their experiences working with us, talk about what other states have done, and then maybe offer a few suggestions for things that we can do. So I'll turn it over to whoever, Tony or Kim.
Yes. Good afternoon. I'm sorry. This is no longer morning. I'm Kim Estep. I am faculty at the University of Connecticut School of Social Work, the Innovations Institute there. And I am joined by my colleagues, Denise Sulzbach. Did you want to say hi and introduce yourself real quick?
I just want to say thank you for zooming us in and really elevating children's behavioral health. My background is a prosecutor, also working in a child advocacy center where I saw firsthand how systems really need to work together. Otherwise, we as states do fail our children. So thank you for having us.
Tony.
Hi, everyone. I'm Tony Bonadio. I'm a research professor at UConn at the Innovations Institute with Kim and Denise. And I am the data side of the group, but I'm also a clinical psychologist by training and in practice. So I'm part-time data, part-time practice.
Great. So we're going to jump right in. And I know that you all have heard this and probably talked about this a lot in this meeting and prior to the meeting and so on. But as we all know, the pathways to help for families aren't always easy or helpful. And we know that as systems undertake any sort of system reform, that it can be hard for us too, right? As leaders in systems and so on, and even the best laid plans, right, tend to fall short. And we know that systems rely or are built on kind of fail first approaches, and that sounds really terrible. I don't think anyone does that intentionally, but it's those moments when it's like, let's try the least restrictive or the least, invasive, least intensive thing first. And if that doesn't work, then we're going to move to the next one and so on and so on. So that's what we mean when we talk about those fail first approaches. And also making sure that as systems that we're not ruling or making decisions by feeling, but we're really looking at data, we're naming the need, and we're actively seeking out information that supports that. And then we're able to track that as things shift. And ultimately, what we want to envision is a system where families get what they need, when they need, where they need it. But for system changes to be helpful, care standards need to be established and monitored and changed based on data, which we're going to talk a lot about that today, Tony specifically. But we also need to make sure that we're tracking who's not getting the service or the level of intensity that they need. I think sometimes we count, if you will, youth or young people or families that get in, if we're going to count referrals to something or eligibility for something, but we really need to make sure that we're paying attention to those that aren't being supported, because that's where our disproportionate representation comes from, or things like that. So next slide, Kara. And so when we think about bridging that gap, right, as systems, we can own part of this, where we can acknowledge that the current system may not be exactly where we want it, or may not operate exactly the way that we want, but we do know that desired experience. So that right-hand side of the screen, where families have easy access, that we have a comprehensive service array that includes evidence-based practices, coordinated care, and those are the things that increase satisfaction for families. We get improved outcomes, return on investment, and so on. And so when we think about bridging the gap between the current experience and the desired experience, we know that there's actually a better way to kind of undertake these things. But first, we really need to understand the experiences of families, like their experience getting to the system and getting through the system and coming out on the other side. Fancy word for that is care pathways, which Tony's going to talk to you about more. And also guiding our efforts by implementation science, which we'll talk a little bit about, but I'm not gonna get into those details too deep today. But just know that we want to make sure that as we're walking through reform efforts, you know, that we're using information that's available to us. Next slide, Kara, I'm sorry. So what gets in the way sometimes of implementing changes? I think that as systems, we you know, look inside the system that we're in and that we're supporting or that we're working in. And we tend to have these silos where small work groups or system specific control, you know, no one system controls everything, but every system controls something. There's also new initiatives and mandates are always coming at us. And so even if we set a path towards some sort of change or transformation, that we get distracted by everything that's going on around us. And sometimes the folks that are responsible for operationalizing the strategy don't actually have the authority to do so. Or it's like, whoo, this is hard. And I'm not really sure what the path is for getting these things done. Next slide. And so when we think about system design for good and modern system, that there's shared ownership across systems for a very specific and defined population of focus. It doesn't mean that population of focus doesn't shift. Of course it does. But we have to agree that we're going to address issues or challenges, shifts, changes, reform efforts in pockets, right? That what are those shared populations? And how do we shift from kind of that system siloed funding, categorical programs or grants, and look at we all have responsibility for that shared population, and we can all contribute something no matter the system that we sit in, because system ownership is really dynamic and it requires collaboration and innovation and a deep understanding of that shared population's needs.
Kim, can I just jump?
Oh,
I'm just
sure.
going to jump in just real quick on this slide. And this really gets to the heart of what I was saying. As a prosecutor in a courtroom, so many times we had case conferencing where we said, who's going to solve and meet the needs of this child and family? And it was always finger pointing across agencies. And the response is everybody, because no single agency owns these children and families. They're really Indiana's families and children. So we've got to come together with systemic responses. And we'll talk more about that now.
Mm-hmm. And so when we think about creating win-win scenarios, right, like that is like the core definition of a system of care. And what you see on the screen is just an example of a shared population, but it's a shared population across these 4 systems. You know, alternatives to out-of-home care, foster care, that kind of thing, juvenile justice, those alternatives to detention that Denise just mentioned, and in education, that alternative to out-of-school placements or, you know, alternative education settings. And in Medicaid, we want to divert from inpatient stays, hospitalizations, psychiatric rehabilitation, and so on. And we can definitely create these win-win scenarios, you know, to optimize services, enhance effectiveness, and promote positive outcomes for children. Because again, we all have something to bring to the table, and we can build more resilient, responsive, and equitable support for our systems if we do it together and leveraging our resources and supports. Next slide. So when we're talking about leveraging too, we can't forget that there are lots of things going on, federal mandates, pressures, grants, like all the things, system constraints, all of these things. But when we're coordinating efforts across child serving systems, we can actually maximize resources, improve data sharing, streamline service delivery, and so on if we can work toward common goals. And recognizing that all of these things, and these are just examples that you see on the slide, but every system has something going on that all contributes to the broader bucket, if you will, of services and supports for families. Next slide. And so thank you, Kara, for I should have taken out the animations in these things and then I forgot. And so here we are, bringing them all up at once. So when we think about navigating the complexity of the service array, remember that first slide, like it was a little bumpy, a little twisty, curvy. There's also the structures that we put in place as systems where we tend to organize the service array, the provider continuum in buckets. And we typically think about those buckets as maybe a low intensity or prevention, or medium intensity, high intensity. But just know that the main issue is the overlap between services in the different buckets. It can be confusing for families. And honestly, families may need access to multiple things that are in different buckets. And so we have to recognize that we need to open up the provider array so that we can make sure that families are getting access to the things that they need when they need them, no matter where in our service system we categorize the service, if that makes sense. Like if we say, oh, this is a low intensity or a prevention service, but we have a high intensity needs young person and their family, they may need something out of that prevention or that low intensity bucket. And so making sure that we're, again, coordinating across agencies, making sure information is available for families to reduce burden and explore some innovative service delivery models and so on. Because as we know, next slide, please, that families grow up, our children grow up in families, I'm so sorry, and that the challenges that they face impact all family members. So a comprehensive approach to services not only addresses the child's needs, but also supports the family unit as a whole. That family-centered care is essential, that families are the primary caregivers and advocates for their children, that the service array needs to include resources and supports to help families navigate challenges and access the care that their child needs. But when we include parents and siblings, we can prevent burnout, caregiver burnout. We can make sure that families can continue to provide the best possible care for their children. And that comprehensive service array helps ensure equity by providing access to services regardless of socioeconomic status, geographic location, and also recognizing that families, regardless of circumstances, deserve access to the support that they need. And so we talk a lot about person-centered practices, and I would just encourage you all to think really specifically around family-centered practices when we're partnering with children with complex behavioral health needs. Next slide, please. So I'm gonna dip into that implementation science stuff just a little bit. But I want to think about, so if you look at the middle line that's on the slide, this would be considered a youth and family pathway where families have said, uh-oh, something's not right, we have a problem. Where do we need to go to find help? When they do find it, are they eligible for it? Can they access it in a timely fashion that matches the urgency that they feel? And then if they're eligible and can access it, was it actually helpful? And then at the end, we hope that life is better. But for families to experience that middle line, those arrows in the middle, we need to pay attention to the inner and outer context. Silly words, I know. So we're looking at the very top bubble as the policy and management level, and then the practice and community level at the bottom. That in order for families to experience a system where they can say, "Ooh, I have a problem," they can find support that they need, they can get, quick access and so on, that the system has to be thoughtful around each section of that, as well as making sure that they're partnering very clearly with the community and providers to make sure that they have the support that they need for families to have those experiences. And that is really critical to the success of any sort of reform, using care pathway data. The acronym on the slide is the System Reform Support Instrument, the SRSI. Apologies for not spelling that out. That is actually a tool that we use that defines a good and modern system. And so we're actually partnering with Indiana on some work around, let's check in and see what components of a good and modern system we have, where are some opportunities for growth and change. And so that's a tool that we use there. Next slide, please. So when we think about that family experience, we don't know, are we looking at our system and we're thinking to ourselves, hey, this is something that's working, right? This is a pathway that clearly is working. Families get quick access to what they need. It's helpful when they get it and so on. Or is this something that we need to change or we need to interrupt? Meaning that the family's experiences, remember, to and through this system, we may need to actually intervene as a system to change what happens next. And that is an interruption point. Next slide, please. And interruption points are simply points in the care pathway. And remember, families experience to and through the system. Those interruption points create opportunities for us to improve the quality, equity, continuity of care. And by implementing strategies to identify and implement interruption points, such as improving access, enhancing care coordination, promoting cultural competence, and so on, we can enhance the effectiveness and responsiveness of those care pathways, families' experiences for all children and their families. And so Tony's going to talk a little more about that now.
Next slide, please. Thank you, Karen. Thanks, Kim. And, I think, as Kim mentioned, I'm going to use this to and through systems a lot. And so what I'm going to talk about is those pathways, as she showed. So that middle path in her diagram, and really trying to get to identify what those pathways look like. And so when we talk about care pathways, it's something that grew out of somatic health in Europe, really took off in the 1990s, but it's this idea that it's outlining the specific steps you would take for a specific population experiencing a specific disorder. And it's really just trying to organize that care so it's a very clear stepwise approach to how to intervene with different decision points, and so that everybody can communicate and coordinate care around those different decision points. And so we are just starting now to apply this kind of sequential approach to pathways to behavioral health. And behavioral health is a bit more challenging because we don't know the underlying etiology and mechanisms that create some of these behavioral problems. They're very complex and they can come from many different places. And so it makes it slightly more difficult than it would in somatic health. But we are really trying to outline what we do know is what the needs are. And we can use that to kind of guide how those decision processes, or to guide that pathway and those decision points. And so what I'm going to talk about now is kind of the process, the data side of how we kind of identify these pathways to and through care for families and youth. Next slide, please. So we're going to think about this from two sides. So the first side is the community-based services, right? So the services that family and youth have access to within their communities We know that these, knowing that these may vary regionally. So we will talk about that a little bit later, but we really want to know a few key pieces of information about these care pathways. The first one, as Kim mentioned, how did families get into care? So where was that access point? Was it, did they come straight to a community mental health center? Was it through school? Was it through criminal justice? Was it through child welfare? Where was that entry point? How did they get there? And when they got there, did the services they received match the needs that they have? So really getting to that point where we're not letting families, for lack of a better term, fail up through the system. We're trying to match where they are at the point when they contact the system. So what was that experience like for families? What were their initial services? Did those services match the needs? And then from there, what was their process? Did they go up in level of intensity? Did they go down? What other services did they access? And what we really want to do is map that out and then understand how the interplay of the other systems that they're involved in. Again, these are Indiana youth, not any specific systems youth. So we really want to look at this holistically across all systems in which they're getting care to understand how those other systems kind of interact, or how all the systems interact with the services they receive. And so, one thing that I always like to say kind of in this part, and I don't know if it's how people respond to it, is, they always say there's no wrong door, but sometimes the question is maybe there is, is how you come into the system, does that determine the rest of your services? Does it determine if your needs get met? Does it determine what your experience is like with the system? And so really trying to understand all of those pieces along the path. Next slide, please. And so that's the community-based service array side. And then the other side is the residential placement. And so I think we often look at these very separately, even though, like Kim said, in those buckets, those youth overlap, and they may be getting services from all of those different kind of buckets: high, low prevention, or high, medium prevention. And so we really want to look in a parallel way at these youth who are maybe receiving residential placements. And so again, how did they enter the system? What was the first services they received? Did they come in from a different, did they come in from a certain system? Did that impact whether they started in residential?
Hey, Tony.
Yes.
Tony, can I interrupt? Sorry, we're just running behind on time.
Okay.
So, I realize we put an impossible task on you all to talk about this really complicated thing. If I could maybe sum up and tell me if you agree with me or if you disagree with me, right? But as I'm pulling out kind of common themes here, right? I think number one, the idea is that, the whole system matters, right? As opposed to individual pieces of it, right? Number two, families experience the system in ways that are almost unique to each individual family. And our system needs to be flexible enough and responsive enough to handle it. And then number three, which I think is really the most important thing, this is not as simple as a matter of we need this much money in these places and we'll be good, right? I think that's where we hope to get to sometimes, and it's not going to be that simple, right? How do those 3 points kind of strike you?
Yeah, I think that I'm going to adjust your second point slightly. I do think that every family's experience is unique, but I think that there probably are common factors and experiences for families, whether that's the region they're in, the systems they're involved in, maybe it's an equity issue. So there are some things that would maybe predict what those experiences may be like. And so that's an important piece to understand. But yeah, and I think that third piece is very true. You need to know right before you know where to put that money.
Absolutely. So as we consider, sort of our recommendations for the continuum, I do think it will be helpful to sort of center those pathways and that experience as the building blocks for whatever we end up recommending. So, again, I'm really sorry to cut you off. We're on such a tight schedule, and so I really appreciate your time and expertise. Are there any kind of sort of concluding remarks or questions or comments from any of you?
Well, I mean, we certainly, there are examples in the slides. There are, I think mobile response and stabilization services are the ultimate interrupter in a system. And so as you're thinking about those approaches, making sure that that is a part of that good and modern system. And honestly, at the end of the day, we just want to make sure that families, to your point, Jay, have consistent access and availability of supports across the state, that there's standardization of intake assessment and eligibility, right? For access, that needs and resources are matched, and that as a system, we can monitor those pieces. And the more that we can standardize it, the easier it is to monitor. Not that we want to standardize over individualize, but families deserve equal opportunity and equal access. And so we're happy to answer any questions or anything like that.
Yeah, and I'll add one thing and a couple questions here. So I'll add that, so we are working actively with you all, just for the purposes of the commission. We're working actively with you all to kind of apply these concepts to our Indiana system specifically. And so we hope for some of this information to be available. Not all of it. I'm not, again, I think, I was like, can we do this in a month? And you were like, no, I understand. But we hope for a lot of this sort of more specific mapping to be available to the commission as we write our report, which I think will be really useful for the legislature as they see where the gaps are. So, Zoe had a question. Anybody else?
Yeah, back to your continuum slide, two things that I did not see on that continuum that I wanted your thoughts on that were, one was a pretty powerful service to us back quite some time ago before payment structure changed, and that is our day treatment program for youth. So we had a very robust partial hospitalization throughout the state, and since reimbursement and things changed, that has since gone away. And I didn't see like day treatment as part of that continuum on there. Was that like under intensive outpatient? Is that what you looped that under?
It would probably be more on the intensive, yes. I would say. And there are a lot of
I see
states.
that as IOP. So partial hospitalization was one that I thought if we could highlight that. And then also on there was the crisis stabilization services. I know you talked about mobile assessment, but another interrupter is that crisis stabilization that a number of folks are developing for youth. And so I didn't see that crisis stabilization highlighted there. Did you have that? Did I miss it? Is that the stabilization services there under intervention?
Yes, we would actually lump mobile response and stabilization services. So MRSS is a whole bucket that would include both and.
Great, thank you for that clarification.
Other questions? All right, well, this is more of a to be continued because like I said, we're gonna have some hopefully pretty concrete information from these folks in our system. And I apologize for interrupting. I'm just trying to keep us moving a little bit. But thank you so much for your time. And we look forward to continuing to work with you both at DMHA and the commission. So thank you.
Yes, thank you.
Thank you for having us.
Thank you. All right, so I'm going to take the sort of chair prerogative and call for a break. Read the room here, and we'll reconvene at 3:25.
It's totally fine, yeah.
Hi, how are you?
Yeah.
Yeah, it's nice. The weather was great. I'm sorry that you actually mental health crisis. Her granddaughter that's what the one that's adopted. She's probably in a crisis point.
Okay, where has she gone?
She's been to Rite Aid.
Okay.
And she's going to be admitted, it sounds like.
Okay.
Um, With a lot of.
Yeah.
A lot of
Reactive
issues.
attention,
Yeah.
there's a lot of things that go into that.
And so she just kind of started acting out. Steve.
No. How are you? We're good. I thought I could say hi. I am. Yeah, how about you? Yeah. So are you here in? I'm not. So are you presenting? I usually do a little flip at the end. But today, because it's so packed with youth, I'm not gonna do that. So when we do the final commission meeting, we'll talk about it. There's lots of elements. Money and workforce are pretty important too. So, yeah.
Just.
Well,
Psychiatrist.
Framework. That's what I assumed, but yeah, I think when I was trying to quickly run through these. I think Yogi's right, so it makes sense, and I mean. Yeah, Michelle's on the commission. Yeah, that's what I think, yeah. So what else is new? You know, not much. I will keep my mouth shut. I only have one that's not. Otherwise, I've been through three doodler, otherwise I can't pay attention. So. The director of student school campaign. Yeah, he was hard to hear you guys. It's really long title. Essentially, it's like the.
Got all the factors, all of them.
Right.
Exactly.
Yes.
Like all
Like grants, service like programs.
Yeah. Through this.
I could help.
And, but like, I was 25, right? It's like she, like, brain science is real. Like, I watched it, you know what I mean?
Yeah.
It's like, reservation weekend. I thought it was legally, but now you really are a human being.
And so, yeah, I do, because I was a school counselor, like, so overlap with a lot of that work, is because.
Granting, but in some ways it's forced to level up.
I know. No, I'll tell you later. I'll tell you later. Not there, right? That's one thing. Because he has to live at home for the first couple weeks because our house is
So I got you who that goes to, and the example of the federal letter was, what if you guys presented that from Indiana, so what do you think? I think it kind of hurt.
Can't hurt.
Yeah.
And then they're gonna make that, yeah.
It was just never. But when he did that to Bruce, when he rented that building or whatever that's what.
We're streaming.
All right, we'll get started again. For those of us that were locked out, we all realized we should have brought our cell phones. So, all right, hi everyone, I'm Rachel Fisher. I am the Administrative Director for Behavioral Health at Riley Children's Hospital. I'm a practitioner and behavioral health leader for 20 plus years, really working with youth and families throughout this time. Okay. Is it on?
Something happened.
No, I might have to do it from back here. You might have to do it.
If you point it back that way, that's what.
Oh,
There we go. Okay. I was pointing it at you. All right. So we're going to talk about behavioral health funding here. So Riley Children's Health embarked on an ambitious initiative to create a behavioral health strategic plan, a plan that serves as a guide for the state of Indiana. Gathering more than 220 key stakeholders, the strategic plan identifies 4 core strategies, which you see here, and 2 enabling strategies, expanding our workforce and sustainable funding. We recognize that without enabling strategies, our core strategies will not be successful. As we gather to discuss behavioral health reimbursement and identification of the problem, we would like to identifying the solution. We would like to start by identifying the problem as inadequate funding, which results in a workforce shortage. We have an underinvestment of payers, including a lack of coverage and low reimbursement models that's resulted in these shortages. What this has done is it's lead to quality and access issues across our continuum. And how do we get there to solve this problem? So here we're going to start by looking at a journey map. So we're going to look at how we review the gaps in the mental health system and how they manifest in multiple settings throughout a child's life. We've heard lots of different presentations already. Here we'll illustrate the mental health journey of a family beginning with a high-risk pregnancy and unaddressed anxiety in the mother. Mom develops postpartum depression, causing difficulties bonding with her baby as the child develops concerns are expressed over the frequency and duration of tantrums. The safety net, which you've already heard is our primary care offices, doesn't conduct early behavioral health screenings as this is not required and training has not occurred. Often we hear our primary care providers lack that quality time training and reimbursement models, which really prohibit them from addressing the mental health needs of our family in those settings. As the child progresses through elementary school, teachers notice an increase in disruptive behaviors. Instead of treatment, the child is labeled. Mental health symptoms continue to increase, leading up to the experimentation of substances and skipping school. By the time they're in high school, they're admitted in the ED, where they wait for an inpatient bed and upon discharge are sent home without any follow-up care. 2 months later, the youth dies by suicide. While we see this story as a journey map, this story is all too common. This family, like so many families we encounter, miss the ability to engage in early identification prevention through infant mental health, miss the safety nets of the community, schools, and primary care for early identification and screening. Instead of treatment, we labeled and dismissed the child and the family. Often the concern is pushed down the road until one day the child has died by suicide. Everyone looks back asking what we missed. What could have been done differently? Early identification, access to care, and competent workforce changed the trajectory for Hoosier youth and families. All possible with sustainable reimbursement models, quality workforce, and access to care. As someone who has spent 20 plus years in youth mental health, recently joining Riley Children's Health has allowed me to witness firsthand the complexity of the crisis we're in. It's provided a new lens of the complexity our families face. My new norm has now become receiving a call about a youth boarding in the emergency department. Their families have nowhere to take them, concerns for their safety net and the safety of the family, Returning home is not an option, yet this is the only option our mental health infrastructure provides. This youth has been denied placement, resources in the community have failed to provide the proper intervention and maintain safety. Or perhaps they're waiting for a service provider, a psychiatrist for medications, access to care that doesn't exist. Those in the community, law enforcement, teachers, social services are doing their best to provide behavioral health support, but also they're practicing out of scope as they have limited to no training. Besides, this isn't their role, it's their role to educate and do other things. If a family resides in a rural community or for our minority youth and families, access to quality care is even more difficult. Some youth are boarded for days to months in programs waiting for proper treatment to become available. Our system, our safety net is not working. Access to care is not available, therapist caseloads are high. Kids boarding in the ED or in a medical bed is not a standard of care we want to provide. My current state is a 10-year-old now on day 13, waiting for the system to provide adequate treatment and care for him and his ailing grandparents. We live in a system where payer type and insurance matter. We've heard this already today. The type of insurance I have allows certain access to care, availability, and level of service. If I'm financially able, I can pay the private pay therapist to treat my child. If I'm involved with DCS, I can access a different array of service. Our ability to access quality care in a timely manner should not be dependent on who is or is not involved in our care, what type of payer I have, or my family's ability to pay. The system should allow for the various right care at the right time with quality providers. Various studies throughout Indiana have identified the economic burden, both direct and indirect, of untreated mental health. The numbers are staggering, they're in the billions. We also know there's considerable evidence that standard evidence-based practices such as MST and dialectical behavioral therapy, DBT, reduce the overall cost of mental health treatment. The result of a recent study found that overall DBT is associated with a 40% reduction in mental health treatment costs. The most pronounced cost savings are due to about a 70% reduction in inpatient treatment care. After accounting for all mental health treatment, the cost per person came up to about $20,000 that the system was able to save. This moves our mental health system from a reactive approach to a proactive approach. Yet, how do we, as providers, pay for our training? If I had a different illness, cancer or diabetes, I would have access to the best care and provider continuum around, often complemented by the top research and practice to treat my ailments. These medical services are funded to support the research, training, education, and provider needs. In mental health, we hope. We hope for a provider that is trained. We hope for a grant or philanthropic dollars to offer that training. We hope for a safety net to support the family. We hope for access and quality care. We hope that the safety plan works until their outpatient care begins. We hope that the agency does not have anyone leave, causing increased volumes and caseloads. Ask yourself, in what other practice do we fund medical care by hope? We should ask ourselves, while mental health care is vastly different, when will mental health be seen as overall health and treated the same? Is hope what we want to offer our Hoosier families and children? If we want to do better than hope, we must work to reform mental health, which starts with a high quality workforce and reimbursement models to sustain. So let's look at an example of this.
Thank you, Rachel. So a little bit of background, I'm David Burton. I have the pleasure of serving as the Chief Revenue Officer at IU Health. So among other things, I'm responsible for how we get paid and if we get paid for all services across the continuum. As part of that, I'm the senior leader who's accountable for our care affordability plan. If you are not familiar with that, that is a plan that we kicked off in 2021 that was focused at reducing and slowing the growth of healthcare costs. So I share that as a background to say I am a leader in IU Health as a system where the first answer isn't always the price. We need higher prices. But I'm going to tell you in behavioral health, it is the prices. I'm going to walk through the high level chart that I have to the right here. And this is absolutely representative of behavioral health, but is not necessarily unique. We've tried to lay out across the three large reimbursement categories, commercial, Medicare, and Medicaid, for both hospital services on the top and physician services on the bottom. What share of reimbursement, what share of patients, what share of reimbursement, and then what the margin is in each of those categories. And the general themes here are very similar to what you're going to see in healthcare more broadly. So in general, hospitals subsidize physicians and commercial payers subsidize governmental payers. Where behavioral health is a little bit unique is the proportionate ratio. So 90% of the volume of behavioral health is on the professional side. So you don't have this large volume of hospital services to offset. And generally, hospital reimbursement in behavioral health is also very poor. Physician reimbursement across all specialties in the state of Indiana is terrible. Those margin numbers, they're not quite as bad for more interventional specialties, but they are negative numbers across all payer categories. But generally that balances out because the hospital numbers aren't. And in full disclosure, I then shared our 2023 margin. When you look at all services combined, IU Health made about 4% on all of the services that we deliver. Behavioral health, because it's so evaluation and management focused, which for folks who are like, I'm not sure I know what evaluation and management is, right? That is the non-interventional treatment of patients. It's talking to patients, it's therapy, it's assessment of symptoms. And behavioral health is overwhelmingly that, right? There aren't surgeries that are then supplementing behavioral health reimbursement. There aren't infusions that are supplementing behavioral health. So they have all of the undervalued component of the healthcare marketplace. And so if you take that minus 15% margin that we average on the hospital side, and you take the minus 160% margin on the professional side, that means we average a minus 100% margin. So for every dollar that we get in reimbursement from payers on average, we've spent $2 to deliver those services. So as we were talking about what ideas we might have in terms of alternative payment models and value-based care programs, my immediate reaction was there's no way to take a negative 100% model and value base it into the black, right? Like there absolutely is a place for us to make sure that we're incentivizing high quality care and that we're getting the outcomes that we want to out of behavioral health, but we're starting from a place that we're completely underwater. And so, you might ask, hey, if it's 100% loss, and actually it's 200% loss, right? We're spending 200% of what we're earning. Why would we be doing this? Part of it is this is part of IU Health's mission, right? And so we are committed to behavioral health. So even though it is a money loser, and every executive across the entire system knows we don't make money on behavioral health, it's one of the very few services, we're committed to doing better here, right? But I would tell you this isn't an IU Health problem, right? That minus 116% that we get on physician commercial business, I have some of the best commercial contracts in the state of Indiana for behavioral health, right? So that's probably an optimistic look. The other thing I would then add is what's not on here is then the kind of the wealthy super class, right? So when my son was 3 years old, he's 12 now, right? He was diagnosed on the spectrum, and we wanted to see like what kind of help could we get for him. And I used my commercially provided insurance to start with. Access was really limited because there are so few providers in the market and so few providers that would then participate in our commercial market, that my only option was to then go look to a provider who's on a cash and carry basis. And I work in healthcare finance. I'm not shocked that healthcare is expensive. And I walked in and I was told I needed to put down a $4,000 deposit to get my first appointment. And we're not struggling to get by, but $4,000 to get a first treatment was just shocking to me. But that, quite frankly, that is where a lot of providers need to be in order to be able to make margin. Then I'll hand it back over to Rachel.
Thank you. So as shared and as we've heard multiple times today, we need to ensure behavioral health reimbursement models allow for services to be rendered. We know that our services, what our psychiatrists, therapists provide, really are labor intensive. They are more than just an initial appointment. Insurers pay licensed providers, and we look at how we negotiate those rates. Mental health professionals really need to be reimbursed, compensated, and our quality enhanced so that we can provide these services. I hope that you hear that what we want is to provide quality services so that we have access across the continuum. as providers, every day we face risk. We face risk when we work with these families, suicidal ideation behaviors, and we're making these decisions. So we have to invest because it really is lives on the line that we want a quality workforce to invest in, to have services available that are accessible so these families can get treatment where they're at. So what we've done here is we've really come up with 4 different recommendations that we would like you guys to consider. So one's an equitable approach to insurance reimbursement that's comparable to our peers in the medical and surgical workforce. The second is alignment of payers through meaningful financial incentives and removing administrative burdens. It is very paperwork intensive and it gets in the way. Create reimbursement models that recognize quality care and treatment, enhancing rates for providers trained and certified in evidence-based practices. These practices are expensive to be trained in, however, they save money in the end if we were able to get high quality care and access. And to help get our workforce, we really need to provide incentives such as scholarships and loans forgiveness to attract and retain behavioral health providers to create a diverse and representative workforce. We need to be able to show that we have the right infrastructure to make the right decisions in the right time. So just in conclusion, I encourage you all to think, I've been in behavioral health for a long time. Really, we continue to always say our time to act is when and now. And if we sit here and in another 2 years, we have another meeting or another 5 years, how will we know we're addressing this needle? How will we know we're solving the crisis? The crisis is something we're facing every day. Kids are sitting in our emergency departments without a safety net. And I really like following that last person, that system, right? It's not about one thing, it's a system. The family should be able to access that system regardless of who's involved and who their payer is, because these children need our help. So thanks for allowing us to speak to you on behalf of Riley and Indiana University Health. It's an honor to be here and work with you all to serve our children. So thank you guys.
Question, we're having a break, sorry, we're having a break.
No break now, sorry.
Any questions? We have a couple minutes, so questions or observations for Dr. Riley?
Are you guys impacted by the hospital assessment fee?
We are, yeah, so
Yeah.
all hospital or all acute hospitals in the
Right.
state of Indiana.
Yeah, and I think that's something, just knowing who's on the commission, that's something to highlight, that the hospital assessment fee. So we advocated to get that removed for behavioral health, because that hospital assessment fee really is a sustainable resource to us in doing inpatient services, whether we're freestanding community mental health center or Riley. And so I just think that's something from the group standpoint, from a recommendation standpoint, that it would impact not only expansion, but also services for mental health.
And for the commission, no, I mean, I hate to be the voice of sort of doom and gloom here, but like, I think that Senator Kreider and other General Assembly members will say that, this shouldn't stop us, but we are flying in the face of pressures going the other direction, right? And so I don't know if you have any comments on, I've asked all of you individually to think about, ways to kind of get around it, but any thoughts or comments on that?
Yeah, I'm kidding. So I'll know our numbers. I don't have the entire state numbers, but I would tell you behavioral health is less than 0.5% of our revenue and expense. And so it's a big problem, but it's also a small problem. And I don't think you would blow up the state's budget, right? There might have to then be trade-offs, but I feel like you can for kids specifically, you can take Medicare off the list, right? One, the feds we have very little control over, right? But kids are going to be covered by commercial insurance and by Medicaid, right? And this message around investment in behavioral health, we are taking to employers as well, because it is the number when I go out and talk to employers about what we're doing and get feedback from them on what they want. The number one thing they want is behavioral health. And the folks who are then buying healthcare for them are undervaluing it. And so we're pushing that message. The state, which we do have more influence over, is the other large coverer of children in the state of Indiana. And again, I think proportionally, we're not talking about changing reimbursement for the entire state for all services. It really is, my guess is likely less than 1%.
So the reason my number one goal is to get funding for mental health outside of the general fund budget is because you don't want to be in that fight if you look at the budget, I'm part of appropriations. About 88% of the spend that we do each year, it's fixed before we even start negotiating on the excess. And so they talked about commercial payers. One of the recommendations Mental Health America had 3 or 4 sessions ago was look at mental health parity, and talk about a frustrating discussion. The companies don't even define coverage limits the same, so you can't measure them against each other, and you can't measure them against the Federal Mental Health Parity Act. And so it's a big challenge. I think the thing that's encouraging is in the previous presenter, they talked about juvenile issues and how that there's an intersection. We did already. I was a Senate sponsor of the Juvenile Detention Reform Act, and we got a process in place to use a validated screening tool for any kid that makes contact with the system and know whether that's somebody that's really a criminal or whether they need services. And so a lot of the kind of outside work has been done, but this is a funding discussion. If we don't have adequate funding, we just aren't going to attract the workforce that's going to be delivering services. And so that's where I'm at personally. I'm going to be arguing with my colleagues for some cigarette tax, some system, something that will get us an amount of money that we can at least look at and say, if we use this amount, then we can measure progress and we can come back and argue for more.
Just to add on to that, if I could, because I was thinking the same thing when I was listening to it. When we passed the Mental Health Parity Act, it was focused on the person receiving the service. So the financial requirements, the access to services, but it doesn't focus on provider reimbursement at all.
Yeah.
And I don't know if any other state has done that, but parity of behavioral health to physical health reimbursement would be huge and logical and fair.
Maybe that's something we can tweak and have that look at least.
Yeah, because it wouldn't, I don't think, it'd take very much change in the statute.
Just a few words.
Yeah.
Well, when I had brought up parity in my office because of reimbursement rates, the office manager described it to me as these health insurance companies contract outside of their services for behavioral health services, and those contracts then manage that care. And I'm wondering if there's something we can do legislatively to affect that process.
Well, stay in contact with me and we'll talk about that.
If only we had some sort of report or something we could
Yeah,
put these recommendations into.
Well, I would be curious to know what the cost is for behavioral health Medicaid, if we could get those numbers.
I think I know the answer, but so those negative margins, are those more pronounced the more intensive the care? In other words, do you lose more money on the more intensive care that you provide, like inpatient acute?
It's not perfectly linear because again, the contracts will try to reflect a higher intensity service will be higher reimbursement. So it can be hit or miss depending on the payer and the service and the provider type, so.
I think the thing that I just keep chewing on that was presented earlier that it completely, affirms what you all are saying is the $113.46 reimbursement rate in the MST study. We know that's quadrupled if a child actually enters residential care. And so this is like a no-brainer for me. It's just figuring out how to message and thread the needle to say, we can't go on putting Band-Aids, when there's a water leak.
I would say it's more than triple that. It's about 9 times that.
I'd be curious on, because we've done within our system studies regarding not only the difference in margin and cost, but also the extra administrative burden that you have to do for behavioral health compared to some of the other specialties and what that cost is. Have you guys done that and what that cost
Yeah, and
would be?
those largely should be reflected in those numbers.
Okay, okay.
Yeah, so that's not just the provider in the intervention,
Okay.
right? It's them and all of the surround services.
Well, I think just sort of maybe within this, I think that we had that big shocking number last time, right? For, 4.2 billion for the overall cost. I mean, to me, this is sort of almost the equivalent of that shocking number that $1 loss for every, or dollar, whatever, not a math person. But whatever you think, whatever you said it much better, but so,
Well, I have to speak up. I'm on the board of governors of a rural hospital, Good Samaritan, and these numbers, our payer mix is a little different, but these numbers reflect the same, so completely accurate.
I'd just like to say kudos to Riley for continuing because other systems are backing away and we're feeling it. I mean, there are people that are impacted negatively because of.
And I think I just want to point out, it takes a large system sometimes to cover and to sustain. And I do think there are a number of programs that result in closures. And how do we build a system that you don't have to be a large system to sustain and provide, but that we create a system where everyone can sustain.
thank you so much.
Thank you.
Thank you.
You're up.
Ready to roll.
Yeah. All right, next up we have Dr. Rachel Woods, who, we heard from Dr. Adams about the Be Happy program and pediatricians and their ability to access it. So with Dr. Woods, we have a pediatrician who handles, pretty complicated, complex mental health issues in her practice, and also utilizes the Be Happy program. So, as we think about obviously the behavioral health specific reimbursements, we can't only look at that. We have to look at the other parts of our system as well. And so, turn away, Dr. Woods here. Thank you. I love the decor on your slides.
So pediatric. First off, I want to say thank you to Dr. Yoder for inviting me today with the email. I'm very excited to be here. And thank you to our chairman for working with me and getting the presentation together. So let's get rolling. Okay. So today I'm just going to talk about Columbus Pediatrics. What kind of a practice are we? What kind of patients do we serve? Our demographics, and then the trends in our practice. And I'm going to go through a case study and give you my thoughts on what I think is going on. Okay, so Columbus Pediatrics is part of the Columbus Regional Health System. We have about 9,000 patients in southeastern Indiana. So we serve Bartholomew County, Jennings County, and also Jackson, Decatur, Scott, and Jefferson counties. So we're very rural. Our Medicaid patient base is over 30%, so between 32 and 34, depending on the year. We have 8 physicians in our practice, and we also have a pediatric hospitalist team to care for newborns in level 2. That is the basics of our practice. On a side note, if you're coming to Columbus, please let me know. We can hang out. We're known for our architecture, so I can take you on a tour. I would describe Columbus as a hallmark town. So now anywhere I go, I'm going to see a parent or a patient or both. So I have to be ready. Kroger, the gym, Ulta, everywhere. I see someone I know, so that's kind of the vibe of the town. So if you're coming, just let me know and we can hang out. So some of these patient demographics were pulled by my office manager. So I looked at ethnicity specifically. So the non-Hispanic Latino is the greatest, but that includes white, African-American, and others. And then it goes all the way down. What's unique about Columbus is we do have an international population due to Cummins Engineering. So we pull engineers from India, all across the world. So despite this graph, it doesn't really reflect our unique diversity that we have. So there is some diversity there, just due to the engineering company that's there. Yep. We also recently had an influx of refugees from Haiti. So we're working on our Haitian Creole. Good luck to me. We also had some Afghan refugees a few years back. So every once in a while, the town changes. But for good reason. So these are trends in mental health diagnoses after COVID. So this graph is limited because in 2018, we switched to Epic EMR. So inputting those diagnoses, the data is not as strong for me to show you what things look like before COVID. So that's why I only have the graph for the past few years. But if you look, you can see the diagnoses by age group. So I've included depression, ADHD, anxiety, and kids who have 2 or more diagnoses. So you can see as the ages go up, you see more percentage of those diagnoses and even the 2 or more. So this reflects what is challenging in general pediatrics, is that we're seeing increased numbers of these mental health diagnoses. And I really address those in 30-minute increments. So that's what makes it hard for me. I probably need an hour, probably need a year. Like I might need a lot to address that, but 30 minutes at a time. So sometimes that's not enough time to get to what the kids really need. The other thing that's not reflected here is the increase in patient calls immediately during and after COVID. So that's 2020 and 2021. We cannot link our calls to diagnoses, but our practice, as well as the other pediatric practice in our town, noticed alarming increases in parent calls due to mental health issues when the kids were specifically shut in at home. So that's not reflected here. And I wish that I could reflect it, but we did see a lot of calls. So our actual patient volume slowed down during COVID. We actually saw less patients, but we got more calls about acute behavioral issues and things going on. So now we're going to move to a case study. I'm going to call my patient DJ. So he's a 10-year-old African-American male, but I met him when he was 2. So I've known him the whole time I've been at Columbus Pediatrics. And that's part of the reason why I chose him. So when he was born, his mother had intrauterine drug use. And before he was removed into his new home, he had a history of physical abuse and neglect. He has all those diagnoses there, which kind of show forth all together sometimes. So ADHD, oppositional defiant disorder, reactive attachment disorder, post-traumatic stress, anxiety, and depression. So on our next slide, we're going to follow his mental health timeline and kind of see what happened to him. Okay, so around age 2, I met him as he was removed from his home and placed into his foster home. What's unique about Desmond is that the home he was placed in was actually family. So it was an aunt and an uncle. So that's where he was placed at age 2. However, by age 5, he started showing very worrisome behaviors, violent aggression, throwing things. I think one time I got a call that he got in mom's van and drove over his bike when he got angry. So those are some of the calls that we get. So he begins intermittent therapy, but it's not consistent. And then I screened him for ADHD, which he tested positive for, and started trying medications, which didn't really seem to help him. By age 8, he had his first short-term mental health admission. He's had 2 of those. And by age 10, which is this year, he's now in long-term mental health placement for 6 to 9 months. So he's now been placed at age 10. A few things I want to address. So from birth to age 2, he did experience some trauma with his birth mother, abuse in the home, but he also experienced abuse in his foster home. And that's very unfortunate because that was supposed to be a safe place for him. And no doubt the behaviors that I started seeing were due to the abuse that he was suffering there. In fact, he wasn't removed from the foster home because there was nowhere for him to go. Couldn't go back to bio parents, couldn't go to other family. He just stayed in the home. So I wanted to highlight all the ways that some of you in the room have touched his life and that he's actually interacted on some level. So we start to see DCS involvement in 2014. He would have been 1 or so years old there. Again in 2015, when he was removed from the home. Again in 2019. And then in 2021, there's an asterisk there because there were 2 occasions where DCS was called. And this was the time where he was experiencing abuse in his foster home, which is now his adoptive home. So I'll tell you a bit about that case. When I first saw him for that occasion, mom presented to the exam room with a black eye. I asked her what happened. She said, the child did it. I said, the child, did this happen? He said, yes. And I said, are you safe? She said, yes. And I sent them home, still calling DCS. He presents a few weeks later. Now he has bruises on himself. And I say to the child, what happened? He said, my uncle hit me. And I talk to the mom and I say, hey, what happened? Did he hit you too? Is that how you got your black eye? She said, yes. So she had assigned this violent behavior to a child who never did that. And what is the trauma of that? And what are the effects on him of living in a home that's supposed to be safe, but where he's been identified as the aggressor, when that's not necessarily the case. So I think that a lot of the behaviors I was seeing from him, or I heard from him, were due to that. But how do you address that? Where it's the family system that's broken. And I cannot refer the adoptive mom to therapy, although I wish I could, so I just kept referring him. He's also seen Riley Developmental Pediatrics, Adult and Child, Centerstone, and was referred to Riley Psychiatry before he got placed into long-term care. So then we move on to Riley Be Happy. As we learned earlier, they were started in 2019. So these are his number of calls. And you can see in 2021, I had 3 calls due to his behaviors, just how to manage them. So in a sense, I do think that trauma really can't be medicated. And that's kind of where there's a gap, because I've been asked to address his behaviors, but they're due to what he's experienced. And there's no medicine for that. So it's hard to educate families and say, your child has been traumatized. I cannot medicate this. It is going to be hard. Like, will you work with me? Will you work with these services? There's no easy fix. I can't just give them a pill. It's very hard to educate families on that, especially since they're with him 24/7. Again, I see him for 30 minutes here and there. And he's a cute kiddo who gives me a hug. I would hang with him if he was like that all the time, but apparently he's not. You know, so very hard for parents. The medications he's been on, the methylene is the start of his, we'll say medication they given. So all those medications, a lot of those are for ADHD, Zoloft for depression, Culprit is for ADHD and Concerta as well. But he is on such a regimen. I didn't write it down because it is staggering. He basically takes medications 4 times a day. 4 times a day, he has some medication in his system 4 times a day. That's a lot. That is a lot. I will say, through calling Riley Be Happy, the overall trend of their recommendations were therapy. So I am happy about that. So even though I consulted and said, can you help me adjust his medications? The overall theme was therapy, please, and more therapy. So I think that speaks to properly addressing what his problems might be, even if he had limited access due to where he lives or who's in the area. And then those are his inpatient stays. And so now he's somewhere in Indiana for 6 to 9 months as of February. So that's where he is. So questions I have that I think about, which you may not know the answer to, which I don't either, is what is going to happen to him when he gets out of that 6 to 9 month stay and he goes back to a family, which triggers him. So I think maybe one of the weaknesses of long-term stay is that it doesn't address triggers in real time to the behavior. You know, so when you are in inpatient stay with kids you don't know or adults you don't know, that outcomes that they want you to have may not even be successful when you go home, because now you're back with everything else that set everything off in the first place. So I do worry about him and I wonder about him. I don't want his future to be that he's just institutionalized. He's 10 years old. He's just a decade old. I don't want that for him, but I don't know how it's going to go. So I don't know. So this case study, I wanted to highlight the effects of trauma on how you initially presented and what happened. Also, there's a generational trauma that I think a lot of pediatricians and family doctors see. In some sense, this could be addressed by maybe at-home therapy or at-home interventions, but so much of it is generational. And I try to encourage the parents to say, you cannot go back in time and change your own traumas, but you have to get better for your child. You have to get better for them. You know, I can't help what happened to you, but you have to get better. So pushing the parents as well to address their traumas and the things that happen to them so that they can show up for their child and help them through it. And this is just my conclusion. I think I said a lot of that. I won't repeat myself. So thank you to everyone. If you do your best thinking at night like I do, you can email me later and ask me questions. Thank you guys for having me.
I just want to say thank you. I'm going to be using this quote forever and ever now. Trauma cannot be medicated. And your observations about ADHD and the correlation between inattention and trauma, I mean, that's just that. I don't want to say it's a misdiagnosis, but we're trying to manage a symptom where the root cause of that cannot be medicated. And so there is so much work, and I know you're probably aware of Project Echo and the work that's done. So when you have time to sit on those circles, I think you'd find the conversations fascinating. My academic side attends those pretty regularly, and I think we're all clinicians, academic researchers are all trying to grapple with who are the trauma providers, and the answer is we all are trauma providers. And so I just want to say, Dr. Woods, thank you for digging in deep to that.
Did you have trauma-informed care training as part of your, so where did you, that quote also stuck out to me, like as a pediatrician, where did you learn that?
I think it's the type of patients that I see. This one, he's just one of them, but there are so many where the kids are just placed into the circumstance. They're just placed there through no fault of their own, and they experience just a lot that no kid, no person should experience. I have a high number of mental health patients, a high number. So I think that's where that came from.
Early in your presentation, you had the number of patients, number of physicians. Remember, it's 9,000 patients and 8 doctors. I'm not a math person, but that seems like a lot of patients per doctor.
It is.
Is that a common?
I don't know. I know that for our full-time doctors, we each have 1,400 to 1,500 patients. And the full-time schedule is 4 weekdays with occasional Saturdays. And we don't have any nurse practitioners or other providers.
That has to make it hard to remember what's happening with each of your patients as you're providing care.
The ones I see more often, like him, I will never forget.
You remember what it sounds like.
Yeah.
All right, well, thank you so much. That was wonderful. And it's actually a really good segue into David Reed, commission member from DCS, who we followed by Michelle from DOE. Just kind of talk about the impacts of kind of the circular conversation, the impacts of behavioral health on DCS and DOE, as well as the things that they're working on with us and other people to help address that.
Thank you, Jay. Thank you all for a chance to speak with you today. I know I'm mindful of the time here and I have a lot to kind of throw at you. So I might feel kind of disjointed. I apologize in advance for that. I'm going to go ahead and just dive right in. I'm going to skip our mission, vision, and values here. We don't have time to go through that, but they were recently revised. I want to share some quick data with you. So what you're looking at here are the number of DCS CHINs, so kids in need of services who are in treatment facilities, going back to 2017. I've been with the department now since September of 2017, so right around that time. And back then, we actually had over 1,000 kids in treatment facilities who were wards of the state. You can see that has consistently gone down. So that's where we've been April 30th of each of the subsequent years. So we're down to 423. It's actually an all-time low for the number of kids in treatment facilities who are wards of the state. So we work really hard to try to keep kids with families. Kids should grow up in families, not in institutions. And we know that really clearly in the research and the data as well. It's a really important goal for the department. We tried very hard to develop new initiatives to improve and reduce the number of kids in these facilities.
David, does
Please.
less institutions weigh?
So
in that?
great question. So we have reduced obviously the number of children in these beds by more than 50%. The number of beds themselves are down 5%. So it is not a reduction number of beds that's caused the reduction of kids in them. It has really been an intentional effort to keep kids out of facilities where we can. But the kids who are left are challenging. That is a very obvious theme that we see with our young people, that the ones who need this level of care have high acuity issues. So much so that many of our providers really struggle to meet their needs or even be willing to admit them into their facility because of their acuity. We'll talk more about that here as well. We have another program for our severely mentally ill kids. There's actually two programs that provide high fidelity wraparound, intensive wraparound services. There's a CMHW program for kids who have Medicaid through DMHA. And there's the CMHI program, which is the DCS program for kids who don't have Medicaid, have private insurance or no insurance, or who have an exclusionary diagnosis. So CMHW is not really designed or prepared to work with young people who have developmental disability. So those youth also come to the CMHI program. The number of kids in the program right now, we're at 921 kids across the state that are in that program. Again, that's the DCS program. About the same number in the CMHW program through DMHA. 560 of those youth have private insurance, 11 have no insurance, and again, 350 of them have those exclusionary diagnoses that make them inappropriate for the CMHW program. And I think important for us to note is about a third of those kids that are in our program were previously adopted from foster care. And I think this kind of myth that adoption is all sunshine and lollipops is not based in reality. Adoption is complicated. And young people struggle as they go through their childhoods and adolescences, and families struggle to meet their needs. So I think it's really important for us to be aware of that. And for the youth that are in this program, they all have intensive mental health needs. We've gone up about 100 kids a year, 5 years in a row for kids that are in this program. It's important for us to also be mindful as well as discussions around high acuity. And it's increasing across our state and with our young people is clear. And we're seeing that as well in this program. Again, we want young people to be with families though. We try very hard even for these young people to keep them with their families. And in fact, only 24 of these kids are actually in facilities. The rest are all with their families receiving high fidelity wraparound services. So there's the actual numbers. So 24 of the CMHI kids are in residential treatment. And that's stabilization. So when we use that service, it is for crisis stabilization. But we do have kids that are waiting. We have 7 kids right now, DCS wards, who are currently waiting for state hospitalization. 5 have been approved for admission, but don't have an admission date. And to be clear, state hospitalization, that is for, again, crisis stabilization. So we have people who are in crisis, who meet the criteria for stabilization, but the bed's not yet available, mostly due to workforce challenges that we are seeing. It's been pretty well documented in all of our discussions today and our meetings as well. We have 2 that are pending with gatekeepers for their approval for admission. In addition, we have 54 young people who are over age 18 who are still in the DCS system who are waiting for their BEADS group home. So their adult group home placement, because there are no child or adolescent group home placements for young people who qualify for BEADS. So they end up with the Department of Child Services. We kind of become the default mental health service for kids sometimes across our state when our other resources are not sufficient to meet their needs. We have another 18 youth who are not yet 18, but who will qualify for BEADS placement when they do become adults. These are vulnerable youth. So there's the other 18 that are waiting for those adult beds. So to try to make sure that we are able to keep young people in foster care, even our higher acuity kids or with families, we have developed a new service that's going to be launching statewide this October. We had an RFP that launched back in December. It just closed in April. And I'm really excited about this service to be able to hopefully keep even our more challenging kids with families where we know they have better childhood experiences. Kids should grow up in families, not institutions. So these are services for even our more challenging kids to be able to stay with whatever family makes sense for them. And that can include relative or kinship families. Actually, believe it or not, over half of our kids, over half, when they are removed, are placed with relatives or kin. We want to try to minimize trauma exposure for our kids and work really hard to put them with relatives whenever we possibly can. But what happens next is critically important. And if those placements disrupt, we've harmed that child. That's clear in the research that when kids are rejected by their caregivers, there's a mental health consequence to that. So we want to be able to create these services to provide more supports and resources wherever the kid is. So if we place with grandma, most of our grandmas are of working age. These aren't retirees who are home 24 hours a day. They have to work. And if the child gets suspended, that's a crisis. If you want to create a family crisis, suspend the child. She'll probably tell you about that when it comes to how schools interact with this population as well. So intensive foster care provider, whoever gets the contract, and we're hopeful of having a provider in every county in our state delivering these services, they have to pay the caregiver, whoever the caregiver is, whether they're licensed or not, what at least our current maximum per diem for foster parents. And our current maximum per diem is $76.41 a day. I'm confident that if we provided those kind of resources to relative caregivers, we're going to provide better, more stable and safer care for our young people. And to your earlier point, Representative, it'll be an investment that can help us keep kids out of facilities and actually save dollars, but more importantly, provide a much better childhood experience for kids who need us to step up. And the hope again is to have these contracts in place in every county by fall of this year. Again, I know I threw a lot at you guys quickly here. A few more things. First, talk about in terms of ways for us to collaborate better with the department and other state agencies. Working with DMHA and VEDS on strengthening our service continuums is a big topic today, obviously, because there are gaps in our continuum, especially when it comes to the more intensive outpatient services that just aren't available. So we go from traditional outpatient to acute inpatient with not a whole lot in between. And then when they discharge from acute inpatient, which usually is 7 to 10 days, they're not stable at that point. There's not really a good intensive service available to meet their needs. And again, so when families don't get their needs met, it's not uncommon to call us. We get calls regularly from parents saying, I can't do this, come get my child. And that is a really sad occurrence for a family to have that be the experience. And imagine what that feels like for the child, to have a caregiver say, I can't take care of you any longer, and to have folks like the department come in to their lives. So work with providers on reimbursement structures and other barriers to more intensive outpatient services. We have a program we launched statewide June 1st, 2020. It's per diem based reimbursement. That program they mentioned earlier for the MST, the 113 a day, that's the DCS program. It's per diem based reimbursement. It helps providers be able to anticipate their revenue so much better and provide more intensive care to the families who need it. And it has really helped us produce better outcomes for kids. There is clear data that has been a big step in improving outcomes for families and kids across the state who are involved with the Department of Child Services. Then explore opportunities to diversify services available by CMHI and CMHW. Wrap around right now with the intervention approach. Can we do some other kinds of interventions collectively with the Department of Child Services and DMHA to meet the needs of youth who don't qualify currently for CMHW, or maybe aren't a great fit for wraparound services. Then also work with DOE to find ways for kids to stay in school. Like I said earlier, if you want to create a crisis for a family, suspend the child. Because again, most of our caregivers have to go to work, and our kids can't be home by themselves. We know they've got pretty serious behavioral problems. And so we can keep them in school where they're getting educations and they're getting their behaviors managed and they're able to be supervised. That'll help prevent those crises for families. More opportunities for collaboration. Review of our acute hospital admission criteria. That can be a real challenge. DCS, I think, is part of the problem there, to be honest. But sometimes when it's DCS as the referral source, providers aren't very excited about admitting that child because there's complexity with DCS involved kids, and families aren't always engaged, obviously. And like we said earlier, family engagement is the best predictor for how well a kid will overcome whatever mental health problem they have. And if there's not family involved, that child progressing, the likelihood of that is definitely reduced. Review PRTF programs and contracting to improve access. Those programs have been kind of diminishing across our state over the last several years. And finding also ways to make sure we have funding covered for youth who don't have Medicaid or have lost their Medicaid, because those kids also oftentimes become wards of the state of Indiana because their family lost access to their coverage. And then again, review state hospital admission processes and treatment approaches to ensure that there are no youth in our state who are too acute for the services that we have available, because that is also a pretty common outcome, that no one will accept this youth because their acuity is so great. We have to find a way to make sure that there are no youth in our state that we can't meet the needs of. Happy to take any questions anyone might have. Yes.
David, that was great. Thank you. Because of what you talked about, you know, reactive attachment disorder and the evidence, the focus to stay with kinship placement, what sort of training do familial providers receive?
I love that question. And so people, when we talk about doing intensive foster care, they say, why don't we create like these specially trained foster parents that have kids move into the home when they need it and then move back out when they're stable? And research is out there, point to any study that says moving a kid 3 times gets them to a good outcome. It doesn't work that way. So I want to bring in an expert, wherever the kid is, with grandma, with their aunt, in the DCS foster home, and have them provide the support, financial dollars, and the expertise, help them understand trauma exposure, help them understand the importance of routines and structure. Our kids do better when there's good routines. They can predict what's going to happen. And when kids have experienced trauma, having things be predictable is so important. So we want to have experts teaching grandparents about bedtime routines and shower routines and homework routines, the kind of things that if we do them right, will minimize behavior problems, we'll have kids who are feeling safer, and they'll have much greater placement stability than if we aren't doing those things, then we have to move to some special home and get better and then move back out. I want them to stay.
Exist, right? Is that?
So you can get licensed. So relative, I've always had the ability to go pursue a foster care license, and that does provide up to 20 hours. If you go with an LCPA, it's 20 hours of pre-service training on things like trauma informed care. A lot of it's about understanding DCS systems, to be honest. But some relatives can't get licensed because of their home being too small or because of their own background check issues. DCS, I'm grateful for this, starting July 1, 2023, provided a stipend for all relatives, even unlicensed, $300 a month, which isn't enough, I will be the first to admit, but it's a big step in trying to help improve the placement stability of these youth who, again, over half go to relative care. And if they aren't licensed historically, they got no support financially or very little. Now $300 a month per child, which has made a difference in helping support those relatives better so those kids don't disrupt.
So perhaps that could be an opportunity to develop some sort of trauma training for kinship, incentivize that they do the training and add that to their monthly stipend.
100%. So we asked providers during the RFP, for instance, the foster care, to submit their ideas. And I expect there'll be ideas around exactly that. Educate caregivers, whoever they are, about, again, trauma-informed care for kids who've experienced those trauma.
All right, one quick question.
Oh, it's more of, I want to thread the needle to what you said about the family preservation program that you did with the per diem, paying providers a rate that they could afford to do the expectations of the care based off of what Riley's presentation was. I'm not getting paid enough to provide that adequate care. And so I commend you for your leadership and your brilliance on that program. And I think the data that he has would be something that we should highlight, that if you pay the appropriate amount to providers to do care, you will see improvement in outcomes, and your data shows that. And so with the family preservation program. So I think highlighting some of that in the commission report could thread the needle back to Riley's point.
Like a proof of concept.
We've talked about
yeah.
equity a lot, and we've
Yes.
seen in that program a dramatic reduction in our removal of disparities by race,
Yeah.
which has been so encouraging to see. That's been a really stubborn problem in child welfare for our entire existence, really, but we've made significant progress in that really important area.
We've talked, extreme amount of collaboration across all providers. I think in this instance, this is the biggest issue in my county. Currently, the biggest financial burden is youth detention. I have an exploding number of chin cases, even though it shows different on this chart. we've implemented a family recovery court where we do training with parents to try and implement this, but at some point in time, we need to have the judicial system at this conversation. They are one of the main players in all of this, in my opinion.
And your county especially has had challenges in that area, pretty well documented and
Still,
recognized the impact of your.
we need, the judicial system is also a major part.
All right, we're gonna, thank you so much, David, that was great. We're gonna end with schools here, a couple presentations. Michelle first, and then Dr. Oliver to bring us home. Thank you for your patience.
I will don't talk too long, but just to give you a kind of a highlight. And originally I stole this graphic from Riley. Luckily they're not here. Well, Rachel's here, but just shows a good visual of saying that, you know, Lucas Oil Stadium filled 3 times as the youth mental health crisis. And so we've been kind of using that when we've been talking with others, just to kind of share kind of the amount of students and children that are being impacted by mental health. That's just a visual we used. And the data, so this data was brought up earlier in today, so I'm not going to belabor these statistics, but schools are feeling the impact of this data. I've not been in a school since 2019. I came to the department, I was a former school counselor, an educator, and even prior to the pandemic, I was feeling these statistics in my work as a high school counselor and middle school counselor. But our students are struggling, and the schools are also struggling to provide the support that is needed on a daily basis for these students to remain in the classroom, being educated. It's just been a very difficult road. And I kind of wrote this down, like primary care teams. I think schools are also challenged to provide mental health services, even though they may not be the main people that should be providing the mental health services, because those students are in school and their parents have to work. And so schools are doing their best to provide behavioral support, mental health support to keep those students in school. But it's been challenging with the increase in mental health concerns. And then this is some anecdotal data that we pulled from an Indiana school counselor survey this past school year. So we partner with Inspire Success, and they gather some data around specific to school counselors. And so I pulled some of this anecdotal information, just talks about school counselors indicate that the mental health needs of K-12 students continue to be extremely high. As you can see, the school counselor said the mental health of kids is awful. We need more help. A therapist in schools would be awesome for those that need help beyond my expertise. And then 84.6% of respondents indicated that their school has an agreement or an MOU with a community mental health partner, but more than half, so 62.6%, indicated that the availability of those mental health therapists is not sufficient. So they're struggling, they can put the student or refer the students out for services, but they're struggling to get them in an immediate time. So the wait times for our community health partners is high right now just because of the workforce. So it's nothing that the partners are doing, it's just they don't have the therapists to provide the services. And so now that you've got highlights of the data in the K-12 space, just wanted to briefly talk about kind of what we're doing and seeing as a solution. So I pull this slide up a lot when I talk to folks about what's happening in schools. So on the left, we talk a lot about MTSS, so multi-tiered systems of supports. The goal in school is really to be providing prevention-based services to all of our students. And so you can see 80% students should be in that tier 1. Tier 2 would be more intense supports and services with a smaller group of students. And then tier 3 is really our high flyers. What we're seeing when schools call us for support and help is an inverted triangle. So they're living in crisis mode. So they're trying to service all of these students in tier 2 and tier 3, but they don't have the time, the effort, the resources to provide that support at the bottom. So we work with schools, like I said, on a multi-tiered, multi-domain systems of support. So we are encouraging our schools to do district-wide programs, activities, and curriculum to benefit all students. to hopefully decrease the number of targeted interventions and support and intense interventions and support that are needed in the higher levels. And so one of the things that we've done is we have really worked hard to talk about an Indiana model for comprehensive school counseling. So school counselors work with social, emotional, academics, and college and career. And so we really want to ensure that school counselors are doing the work that is intended for them to do. And so providing opportunities for them to learn and understand how to be data driven. So they're providing programming for students based on the data that they're receiving from their students. So that might start with looking at their academic, their behavior, their attendance, and then providing resources and support that align with the current issues in the school. And so we've provided a platform for school counseling programs to go through and work through to identify, to assess their program, to look where they're providing their supports and services. Because sometimes what you'll see is more reactive school counseling happening, so they're reacting to crisis, but there's no real program that is supporting that bottom tier. So just making sure that those schools are working through comprehensive school counseling has been an important mission for us at the department. And also this then helps the school counselors provide the college and career readiness that is needed right now more than ever as well. So just wanted to highlight this. If you want to check out the website carryingthetorch.org, you can. That's where all of our comprehensive school counseling lives. And then just to highlight too, we've been partnering with DMHA on the benefits of implementing a comprehensive school mental health framework. So I focus a lot on school counseling, but we also have school social workers and school-based therapists, and we all work together as one. But sometimes the framework is not there in schools. And so you've got roles that are overlapping, they're not providing the supports that are needed. And so when you have a framework for schools to really look and identify how they can best serve their students, it's allows the services to be provided in a more streamlined way. So better academic outcomes, obviously access to care. Students are 6 times more likely to complete school offered treatments. We're often the front lines for parents. So when they don't know what to do, they go to the school, they ask for help from their teachers, from their school counselors, from their social workers, et cetera. Early identification and intervention, because the students are at school for 8 hours a day, 5 days a week. And so as teachers are able to pick up on some concerns there. School safety and climate. This is the IYI Kids Count data book showed that 25.9% of Hoosier high school students reported not feeling safe at school. So this would help us to provide and address promoting positive school climate and school safety. And then it also can help with positive youth and family engagement. So really having the families be a part of the process as well, and focus on their well-being. So I'm not going to go into depth on this because Brandy is going to talk about the framework. But if anyone has any questions about the department or any would like to know more information about the work that we're doing in this space, feel free to reach out to me. And like I said, I also work very closely with Bethany Getz. She is the director of school and community-based programs at DMHA.
All right, thank you so much, Michelle. We'll roll into Dr. Oliver and then we'll just wrap up with this section. Thank you.
Yes, I am last. I promise. Hopefully I can, listening to all of it, there's so much overlap. So thank you for having me today. I'm Brandy Oliver. I'm a professor at Butler University in the College of Education, specifically in the graduate counseling program. All right, so yes, Michelle gave you a great overview of what it means to when we think about comprehensive school mental health. We have had the opportunity to really work collaboratively with the Department of Education and also with DMHA, and we really appreciate the funding that's been provided to develop a framework that has a lot of detail and also outlined specifically for schools to walk through this model. And so yes, Michelle talked about MTSS and just to really like, what is it that schools need for students, for families, for community members, and also the teachers, right? The educators and buildings that we can't forget about. So what I am gonna just give you a really like high level overview today is there's 6 core components of what we've identified as essential in comprehensive school mental health. And I really think that these 6 core components have been addressed in almost all of the presentations today in one aspect or another. So if we think about the school climate and culture, kids need to feel safe, right, going to school. Teachers also need to feel safe going to school. So I have 4 kids, 2 of my oldest 2 are daughters, that one teaches in Florida, one teaches here in the Indianapolis area. And they both have had times during their teaching that they've not felt overly safe because of something that's happened in their school community. And so just thinking about, there's so many different levels of school climate and culture and safety. So then we think about mental health and well-being. And so that includes all the things that we've been talking about today. You'll see, I think, everything that is popped up there. But also, even though this is a topic that's so familiar in this room, there's still many families and many students that don't want to talk about it. So that stigma we know is real. And so we still need to be addressing that stigma piece that's connected with mental health. Social emotional development. And so that contains things like the Indiana invested in social emotional learning competencies. So how are we doing this in the MTSS model so it's preventive and we're not just reacting? Also thinking about the social media that we heard from today is really essential. So what are we putting in place to teach students about mental health and social media, their use, maybe parent education, all kinds of different pieces. So again, just these are the first 3 components. And then the positive discipline, I've heard about the juvenile justice piece. And so how are we making sure that we're putting things in place at school where we're not suspending or looking for ways to take kids out of the school environment, but we're really working alongside the students, the families, and the teachers to give them the skills, the strategies, the necessary supports, right, to keep kids in school. That school safety piece, which goes back to climate and culture, but we know bullying incidents, obviously, and that can connect with social media, gun, community violence. I know suicide has been a topic today. I also think about school shootings and school violence, and that definitely has correlations to mental health and well-being, right? So just making sure that that whole kind of comprehensive approach. And then as an essential is the educator and student wellness. So we want to make sure that we're looking holistically at our kids are doing well, but we know our kids need teachers that are coming to school healthy and well too, right? So this is kind of that 6th core component within that comprehensive school mental health framework. There's a lot more information in all those covered minutes, and that's kind of the high level overview. So this is really an implementation process that we're going to outline. We've created these 5 different implementation phases, knowing that every school in Indiana is doing something because they have to, right? Like there's not a school in the state that is not responding at some level, but everyone may be entering at different places. And even what I think of this is a circular, right? Because as soon as they've addressed maybe one area, the data is telling them they need to reinvest in maybe something else. So they might be starting back again at that setting the stage model. So we know you have to have awareness. Kind of the data points are really commonly used, so like what's happening in our community using the data from all of the great resources that we have, understanding key terminology. So just really, that's the essential starting steps, right? Like we have to know what our problems are and what is happening, so we're all talking the same language. So that's where we would say the first phase would be. And then we have this exploration phase that is really understanding in my school what data, like what is the data telling us? And so this could be different resource mapping tools, different surveys, screeners. Schools have access to so much data sources, right? So it could be attendance, it could be behavioral, but really what is the data telling the school and which direction should they kind of focus their attention and their priorities? You have to build capacity, which kind of, you had to do the awareness building right at the beginning. So you're building capacity, you're getting those key champions, understanding what the baseline is. So that's kind of that exploration phase. And then we're getting into the preparation phase, really starting to build the plan, the professional development plan, who's doing this. So not just financial resources, but human resources, the capacity piece. The sustainability plan is really essential. So I've heard everyone talk about funding here. And I'm going to share with you a grant that we have offered to schools, which is great. So we know schools love grant funds, but the worst thing that we can do is give them money for a little bit and they don't have a sustainability plan, because this unfortunately is not going to be an issue that goes away at the end of a year grant or 2-year grant or whatever it may be. So sustainability has to be a significant conversation in their development of this framework. And then hopefully these next 2 make sense, right? Then they're going to take the action. They're going to put the plan in place, But with coaching support, with ongoing, progress monitoring, what's working, what's not working, what partner should be at the table, what partner we're so happy, right? All those types of discussions really in these next two. Again, that continuous ongoing process. So these last two phases are pretty, I think, intuitive of what they mean by that. So we have this model, and I'm going to have a QR code at the end that you can have the website that has all of the information, a lot more detail. But what I'm really excited about is we have been able to launch an RFP for schools around the state to apply for up to $200,000. So we anticipate 3 to 4 schools that will receive funding to do this work. And we, again, recognize that there's a lot of other grant dollars, schools have been doing this work, this isn't something new. But what's really exciting is they're going to have a collaboration with coaching support. We're going to learn alongside these schools to really see, like, where did you start? Where were you in the implementation phase? What core components are you working on? So just to quickly highlight, there's 4 grant priorities. We're asking schools to address at least 2 of those core components, and they have to identify at least 1 grant priority in their project proposal. So it could be promoting school mental health literacy, which again could be more on the educator and family level. Maybe that's that they determine they need to build like mental health literacy with that population. It could be students, it could be both. Maybe it's community partnerships, expanding or creating new ones to increase access to mental health services and supports. Maybe it's increasing school social workers, school counselors. Again, what is it that their school community needs and has access to? Addressing that school safety, positive school communities, or, which I love a lot of the presentations about the systems piece, right? So maybe schools are ready to do that systems work. So really analyzing policies, procedures, what do we need to change about the system here to be better equipped to serve and address the school mental health needs of our students, families, and educators. So those are the grant priorities. And like I said, this is one of the most exciting things that I love about this RFP is we're going to really do this in a collaborative cohort model. So not only will they get to learn from some coaching experts, but we're going to bring the schools together once a semester to Butler's campus and have these teams talk with each other and share what's really working in their communities and what's not working, right? I think we learned so much from I thought this was really going to work well, but this isn't. And maybe do some brainstorming and see what else we can learn from these, again, 3 to 4 schools. And then we will have another round of funding next year for another, hopefully 2, 3, 4 more schools to join the cohort. So if you want to see the framework, that's the QR code. Hopefully it will take you there. But that's a really quick overview of the Comprehensive School Mental Health Framework. So thank you.
Thank you. Well done. Thank you for any comments about schools or questions or anything else? I'm about to collapse into a heap. So
I just wanted to say, I wanted to make sure that we understand that basically wraparound services and MST are the same thing. Okay, that's interchangeable. The issue is sending the children back into the families. We had a hospital in my community that stopped seeing children under the age of 10 because we were just sending them home. So we need the wraparound services and the MST, and the way that we make that happen with legislation is showing a dollar amount of return on investment. I saw where Pennsylvania had done that and where they showed they could save $67 million. So we need numbers.
I also think we need to be very aware with what's going on work-wise in the schools and the support that schools are an access point for kiddos to get services. And so whether that be physical or whether that be mental. And so those school services and having those school services in place, we do need to be aware that there are some folks outside of this group that maybe think differently, but that is an access point that in some of our areas might be the only access point.
There's lots of folks who would disagree with that whole thing we just saw.
Yeah.
So, I mean, that's another struggle.
Right.
Well, we have to be mindful of.
Right.
And I think when we talk about sustainable funding structures too, that there are currently barriers to access for even partners that are currently providers in school settings where, depending on licensure, as we talked about LCSWs,
that you can't bill for Medicaid or you can't bill private payer. And so figuring out how we can use the structures that we can control to reduce some of those barriers when it comes to, you know, them being able to recoup costs for sure. I think the other thing too is that we touched on it very briefly around substance abuse, but right now we only have one school setting in the state that focuses on students who have substance abuse challenges, Hope Academy. And so looking at how we can ensure that they have sustainable funding, and also that we can replicate that model in other areas of the state too. Just wanted to lift that.
That's a workforce solution in my mind as well.
Yeah.
Because we have kiddos in high school that are learning about the power of recovery. That's a peer, that's a therapist, that to me is also a workforce solution if we could thread that needle.
Well, Hope Academy is actually gonna be piloting a middle school project. So there's gonna be even more of a kind of pathway there, a lifestyle of recovery. And so I think there's a lot to be seen here in the next few years with that as well.
Comments, questions? We got a lot of work ahead of us to get from this to our report, but I think a lot of it will be the framing, a lot of it will be the numbers, right? I mean, you know, we have to justify what we're asking for, even if it's, you know, based on projections or estimates, as long as they're defensible. I mean, the 4.2 billion was based on, you know, estimates and projections, and also I think, you know, assumptions, right? And that's okay. So, like I said, I'm going to send out a form for your, you know, just you know, put your suggestions and ideas in there, and if they're, even if you think, you know, you're not sure about some of the details, like we want to collect everything and start wide and funnel, right? And so, you know, that'll go out, and then along with that will be a scheduling poll for our next meeting, which will be, I think, the beginning of the end. So starting to put together a report, starting to put together suggestions, and then really having a conversation about like what it means to focus and understand that we can't boil the ocean, but at the same time we have to be kind of bold and aggressive.
Jay, is there going to be any kind of sequel to the 4.2 billion report?
Sort of a little bit focused on the crisis CCBHC piece of it. That's the component we have not talked about at all, is that part of our task is to sort of evaluate and make proposals for what's needed to finish the job last time. So that on that part of it, for sure. I don't think we need a sequel to that specific one. I mean, 4.2 billion is 4.2 billion. Like, it's not, costs are the costs. I do think we can make some estimates and projections based on our internal data, based on Medicaid, based on DCS. Of, like, for example, we have a great example with DCS's data on MST here. It shouldn't be too hard to extrapolate that to system-wide, right? So things like that, I think we can and should be able to do. But as far as a comprehensive, like, overall holistic study,
I just think that everybody here is talking about the cost benefit analysis and the extent to which anything we recommend, we can put numbers to, has been said. It's going to have more weight coming from the commission than coming from any of us as advocates.
Absolutely, yeah. Well, I think we'll be able to get to some pretty compelling figures.
And is that the WISE study?
The why, yeah.
And then is there any thought with the work you guys are doing on the early onset of psychosis and some of that data and that work that could tie into this too?
Yeah.
Okay.
We look into it, yeah. I think,
Okay.
Yeah, it's all this isn't sort of necessarily messy, unfortunately, from a data standpoint. You know, it's not going to be as clean as sort of like you spend $1, save $3, right? But
Yeah.
you know, I think the goal is to like get as close as possible to a figure like that that's somewhat defensible, where you can show your work and defend your assumptions.
Hey Jay, can I say one thing? I just want to make sure MST is an evidence-based practice, which is different than DCS RAP. MST is how you train the providers to do that intensive level of care. And a lot of the DCS RAP providers, I know Choices is doing it, they're probably doing RAP, right? So they probably have some, but not everyone doing RAP is trained in MST. So I think there's a clarification there that MST is an evidence-based practice that's high fidelity intensive, low caseload. So but there is some difference because not every DCS provider with wraparound is doing MST.
I appreciate you clarifying that, and I think we need to have it clarified moving forward, even for DCS. I mean, we probably need MST involved in that. And to show a return on investment for MST, because once again, we can have the therapy in the schools, we can send them to the hospital, we can send them to the pediatrician's office, but if they go home, right back into what they live in and what's causing these issues, things aren't gonna get better. And that's where we have to start.
I think it's really important that the caregivers gotta be involved,
Right.
otherwise we're gonna have this.
Yeah.
That's what's really clear in the research as well.
Every presenter mentioned some version of work family or caregiver.
And we definitely can have the number and data from the CMHW program, since this is a state plan amendment.
I'm not sure why beads can't be part of that.
I think they should be for sure engaged in those
Yeah,
conversations.
there's a bit
And
of
there's
a
been,
already in the state where we're talking about this actively. We should do it for full. Last words from anybody? All right, thank you.